All right, good morning, everybody. I am Vice Chair Dan Hartong, and I'm calling the Prescription Drug Affordability Board meeting of May 20th, 2026 to order at 8 a.m. Melissa, could you please call the roll?
Yes. Chair Shelley Bailey will be arriving later this morning. Vice Chair Dan Hartung.
Present.
Lori Hoagland.
Present.
Dan Kennedy.
Present.
Michelle Coder.
Present.
Chris Lehman.
Present.
John Murray.
Present.
We have a quorum.
Okay, great. Well, as Melissa stated, I am presiding over the meeting this morning until Board Chair Shelley Bailey will join us around 9:30 a.m. So we welcome everybody to today's meeting. We have American Sign Language interpreters with us today. Please use the Zoom controls to access the interpretation channel on your Zoom software. We also have Spanish interpreters with us today. Will the Spanish interpreter please read the instructions for using the Zoom channel? They are also displayed on the screen.
Bueno, tenemos intérpretes de lengua española. Para ver en español, hagan clic en interpretación, seleccionen español, elijan silenciar o activar el audio en inglés, hagan clic en listo. El español se mostrará en su pantalla como ES. Tienen la opción de alternar entre el audio en inglés y en español. Si necesitan ayuda, por favor envíen un correo electrónico a pdab@dcbs.oregon.gov o llamen al 971-374-3724.
Okay. Our agenda begins first with the conflict of interest declarations, which are stated each month according to board policies. Do board members have any declarations of potential or actual conflicts of interest to declare? Or have board members met with entities or individuals related to board activities? Or have board members provided testimony to the Oregon legislature about prescription drugs? And I see, sorry about that. I see board member Lehman has his hand up.
Yeah, thanks, Dr. Hartung. While we won't be discussing any drug reviews today, I did want to state that I would like to disclose a potential conflict of interest. In my role with Columbia Memorial Hospital, I have leadership responsibilities related to the infusion operations. Because the infusion center administers infusion medications that will be reviewed by the board as part of our 2026 drug reviews, there could be a potential financial impact on my employer. Because none of the board's actions are certain to have any financial implications, I believe this represents only a potential conflict of interest. And based on guidance from the Oregon Ethics Commission, I will continue to participate in discussion and voting on these matters. Thank you.
Great, thank you for sharing that. Any other board members with anything they'd like to disclose? Board member Murray?
Yes, thank you. Under advisement of the Oregon Government Ethics Commission, I need to declare a potential conflict of interest due to my ownership of Murray Drugs, comprised of 3 independent pharmacies in Eastern Oregon that have pharmacy services contracts with PBM's insurance companies in the state of Oregon. Thank you.
Okay. Let's see here. All right, before we approve the minutes today and hear from a program update, we would like to invite U.S. Senator Ron Wyden's staff members to speak. They are calling in from Washington, D.C. this morning. So we have 2 staff members, Rami Major and Stacy Sanders, who are going to be speaking to us. So thank you for joining us.
Hi there, I'm Stacy Sanders. I'm Senator Wyden's Chief Health Advisor. I'm really happy to be with you today. Rami, do you want to introduce yourself?
Hi, my name's Rami Major. I'm a health policy fellow working on Senate Finance.
We're really delighted to be here today. Senator Wyden is a strong supporter of your work, and lowering prescription drug costs has been something that he has worked on the entirety of his career in the Senate. He's really proud of some of the efforts that he was able to pass in the Inflation Reduction Act to give Medicare the authority to negotiate prescription drug prices for the first time, to cap out-of-pocket costs for seniors who have Medicare Part D coverage at $2,000, to make insulin $35 for those same seniors and guarantee that, and also to make preventive vaccines like the shingles vaccine free for seniors going to the pharmacy counter. So he's really proud of those accomplishments, and he also knows that we need to go further. And he really wants Oregon's example to lead the way here in Congress. So the senator has actually launched an initiative this February to identify the next generation of healthcare solutions to lower costs for American families. And his first project focuses on lowering the cost of prescription drugs. So I'll turn it over to Rami so she can say more about the letter. But this is really a multi-year policy development process intended to ensure that Democrats are ready when we next have a trifecta, when we have a president in the White House and a majority in the Senate and in the House of Representatives, to pass solutions that are bold, that are meaningful, and that once and for all lower the cost of prescription drugs for families. Senator Wyden knows, as do all of the Democrats here in the Senate, just how crushing out-of-pocket costs are for patients and for families. We know that families are stretched in terms of their costs on all fronts, whether it comes to food or gas or housing. And so we're really dedicated to providing relief. There are many ways in which the current administration and Republicans in Congress have really made a bad situation worse. They passed the largest healthcare cuts in history in their reconciliation bill. They included a special bailout for the world's top selling cancer drugs, including Keytruda, which is, I know, one of the drugs that you guys will be looking at. And that means that seniors on Medicare will pay more for these drugs for a longer time. So Senator Wyden has really rolled up his sleeves. He's getting to work. He's working with several senators across the caucus. We have 11 members who are in a working group who are working diligently to identify solutions. And I'll let Rami say a little bit more about that, and then we'll be happy to take your questions.
Thanks, Stacy. Yeah, staff is very invested in this, as are the senators. And we've had over 60 meetings over the past few months, really trying to build the foundation of this policy from the ground up and build on what we've done in the past. So the three prongs that the senators are interested in addressing, first is lowering prices that manufacturers charge for drugs. So this could involve building upon the IRA, incorporating international reference pricing into the negotiation process, but really trying to help patients where they need it most and make sure manufacturers are held accountable for the high prices that they charge. The next prong is reducing out-of-pocket drug costs and going after middlemen. So Senator Wyden has really been an advocate for PDAB reform. And so the hope is to build upon that and really go after some of the abuses in the supply chain to, again, help patients where they need it most. And the last prong of this effort is restoring and bolstering American innovation. So Senator Wyden is very supportive of American innovation, especially in the drug space, so that new prescription drugs can be developed that help patients who need it, and trying to preserve that supply chain and those advances, those scientific advances that help patients where they need it most. So happy to take any questions on all of that, but we're really excited to move this work forward.
Great, terrific. Well, thank you for coming to give us an update on what's going on in Senator Wyden's office. I did have a question, and I don't know, you mentioned your first bullet of the prong that you guys are thinking about in terms of building on the IRA efforts. And so I was wondering if you had any thoughts or a position or opinion about, or the office had about the recent, I believe the state of Virginia, the governor just vetoed some of their PDAB initiatives that would essentially extend IRA drug negotiation prices through their PDAB work, and I think that was just vetoed. So I don't know if that is something that is you guys are tracking or have a position on in the senator's office.
Yeah, thank you. And we could certainly look more into what specifically was happening in Virginia. What I will say is that Senator Wyden is very supportive of bringing the prices that are negotiated in the Medicare program into the commercial market. So he believes that all markets should kind of benefit from the negotiating power that Medicare brings to bear, and has long been a supporter of that policy. So it's one of the things that we're looking at, in addition to negotiating more drugs, negotiating drugs sooner, and also, as Ramey mentioned, bringing in a framework around what other countries pay for their drugs. The goal is really to make the negotiations as robust as possible, and put the federal government on the best possible footing when they are in those negotiations with the prescription drug companies, and then to make sure that as many people as possible benefit from those lower prices.
Okay, great. Thanks. I think in our discussions we've talked about essentially all the work that the Medicare program has done to identify what they perceive to be fair prices for the drugs that are high priority for the Part D program, and trying to, and I think extending those to other areas would be a good use of all that effort that's gone underway. So appreciate that comment. Do other board members have any comments or questions for Senator Wyden's office at this point? Yes, Board Member Murray.
Thank you. Thank you, Stacy and Ramey, for coming and speaking to us today. Because Senator Wyden, I'm with Murray Drugs in Heppner, and my wife Ann and I have worked with Senator Wyden for decades, and really appreciated his help in the pharmacy space and lowering the cost of medications to patients. There is some legislation that's bicameral and bipartisan even today that's moving forward with support from both parties and across the aisle, and I really appreciate that, having to do with PBM reform. Hoping that maybe the senator could look at that and see what he thinks about it. I didn't come prepared with the number with me, I'm afraid, right now, but it has to do with restricting vertical integration and ownership of pharmacies by PBMs and insurance companies. And so states have tried to implement this, and they're being fought in the courts quite a lot, as you may know. But there's federal legislation that's being considered. And like I say, it's bicameral, and I think it's bipartisan. I know it is. It's sponsored by both sides of the aisle. So I really appreciate that. But I really thank the senator for his launching of this initiative. It is so important to look at all facets of the drug delivery system. First of all, getting good objective information would be helpful for this PDAB in Oregon, which is a state issue which we would like to tackle. But the federal assistance is so appreciated, so appreciated. We can't be the worst state in the union for access per capita. That's just it's a miserable statistic, of course. So thank you very much for your work.
Thank you, John. Is it the Break Up Big Medicine Act that you're talking about? The Warren and Hawley, Senators Warren and Hawley have a bill on that?
Yes, it is,
Yeah.
actually. Thank you. Yeah, those two.
Yes, yeah, we are very well aware of that bill, and Senator Wyden has publicly expressed support for breaking up big insurance in particular. He's very, very concerned about vertical integration and all of the perverse incentives that it creates, and the opportunity to drive up prices and hide profits. He actually launched a second project focused on private market insurance reforms, very similar to the one that Ramey and I have just described. And that is one of the components of that project. So he has heard, I think, loud and clear from his Senate colleagues. He's watching all of the ways in which this consolidation is playing out poorly in Oregon for organizations like yours, for physician practices, and definitely wants to tackle that as part of our legislative efforts going forward. And to your point, I think the bright spot there is that there does seem to be some Republican support. All of the work that Senator Wyden did on PBM reform was bipartisan. I can assure you that the needs of community pharmacies in Oregon and ensuring pharmacy access for Oregonians was the driving motivation for Senator Wyden in pursuing that work. So we definitely are going to continue to do that PBM work, and where we can find a Republican partner and do it in a bipartisan way, we embrace that. And he is very focused on that. Thank you.
Thank you. Thank you very much.
Board Member Coder, did you have a question or comment?
I was just going to ask about more details about the second lever, which was PBM reform, and that was answered. Thank you.
Rainey, is there anything you wanted to add on the PBM policies that we're looking at?
No, I think, building on the important work that has already been done and trying to go further so that we can have a greater impact is really motivating Senator Wyden and the others involved in this.
Okay. Any other board members have comments or questions? It's a great opportunity.
Well, Dan,
Okay.
can I just close by saying one thing I want to make sure we do is we actually have an email inbox for anyone who's interested in any of these projects to share thoughts or comments. So I'll send that around to you today, both the drug pricing one as well as our private insurance project. And actually today, Senator Wyden launched an initiative focused on reforming long-term care. So I'll also make those resources available to you and those email inboxes so that if you have thoughts or you think of a question that just didn't occur to you right in this moment, you can reach out and you'll get a response. And then just to let you know that we are also looking to kind of craft a opportunity for Oregonians to give us direct input. It's really important to Senator Wyden that while he is doing all this national work, because he is the senior most Democrat on the Finance Committee, he wants to make sure that Oregon stays at the center of everything that we do and that our policies are informed by your experiences, your views, the work of this board. Like, we would love to hear your thoughts and new innovative ideas so that they can be a part of this initiative. It is a long-term effort. I think we all hope that Democrats will have control and will be able to do this big and bold work as early as 2029. So there'll be lots of opportunity to give feedback and share ideas. And we'll make sure that you have those opportunities through a variety of different mechanisms.
Okay, great. Well, again, we appreciate you coming to our meeting to give us updates about what is happening in Washington and in the office. So thank you so much. Appreciate it.
Thank you. Thanks for your work.
Thanks, everyone.
Okay. Next item on the agenda is for us, the board, to evaluate the minutes from our last meeting on April 15th, 2026. And so does anyone have any corrections or edits to the minutes of that meeting? Okay, if there are no corrections or edits to the minutes, then the minutes are approved as presented. The next item on the agenda is a program update from our executive director, Sarah Young.
Thank you, Vice Chair Hartung, and good morning, members of the board. First, I wanted to touch on a couple of administrative housekeeping items. Board members, please take the time in the next month to log into the Workday system and complete your annual board member training for the calendar year. And thank you to folks who've already done their 2026 training. There are 2 self-paced classes in Workday that take about 30 minutes to an hour to complete. And just reach out to Melissa if you have any difficulties logging into your Workday account. Excuse me. I also want to remind everyone that we have a request for applications for future PDAB vacancies posted to the PDAB website. Please share this opportunity broadly with Oregon residents with expertise in healthcare economics or clinical medicine. We are requesting applications for future vacancies now because the process for governor appointments and Senate confirmations takes a considerable amount of time, and we anticipate some vacancies at the end of this calendar year. And if anyone has questions about serving on the PDAB, I am happy to chat. Please reach out to our inbox if you'd like to learn more. Applications for board positions are due by June 5th for consideration in this review cycle, and you must apply through the State of Oregon Workday system. Again, please reach out to us at pdab@dcbs.oregon.gov if you have any questions or any difficulties navigating that system. On to what we've been working on. In April and May, the PDAB team has been focused on collecting and compiling the results of the data call to insurance carriers. We have completed data validation for most of the submissions. We are still resolving a couple of remaining questions to ensure data quality and starting our work on analyzing the data so that we can report summary results and incorporate the data from the data call into those upcoming drug review reports that we will start on at the June meeting. As a reminder, last meeting we discussed the feedback forms that are part of the drug review process. And I want to reiterate and remind folks that these feedback forms on the website will remain open for the next 3 months. We welcome input about the drugs under review from interested parties, and this includes patients, people with medical training, safety net clinics, manufacturers, PBMs, and insurers. The QR code on this slide will take you directly to the feedback forms page, and you can choose the option that best fits your situation. To increase patient access options, the feedback form for patients, caregivers, and advocacy groups was translated into Vietnamese, Korean, and Chinese, in addition to the Spanish language version we had already made available. So please, again, share those with your networks. We held 7 community outreach forums, both in person and online, over the past 4 weeks. Thank you to our host sites for those in-person events and to others who helped spread the word about the events. And thank you also to the board members who took time out of their evenings and lunch breaks to participate in the forums. And of course, thank you to the patients, consumers, legislators, and advocates who took time to join us at those forums. We're in the process of preparing a summary report with information from what we heard from interested parties at the forums, and we'll be sharing that with the board next month. Of course, today's board meeting is also another opportunity for Oregon patients and consumers to share your experiences and your ideas with the PDAB. And I want to extend a special welcome to folks who may be first-time PDAB attendees today. Thank you for joining us. In other information relevant to the PDAB work, in the last month, the Drug Price Transparency Program team has been collecting the annual insurance carrier reports, which are some of the key data used to identify drugs eligible for PDAB review. The carrier reports for 2025 claims were due May 1st, and we have an extensive data validation process to ensure quality control. Once DPT finishes reviews and receives corrections from the carriers, the PDAB team will be able to start analyzing those data to prepare for the 2027 preliminary drug list. Again, that would be next year's review process. And the DPT team has also been reviewing the reinstated annual price increase reports from drug manufacturers, and they will be conducting rulemaking for that reinstated annual reporting requirement. Please check out the DPT website if you'd like to learn more. those are really the highlights of the team's recent work. I do want to take a minute to address another topic. First, excuse me. First, the statute that created Oregon's PDAB. So, one of the things as part of our work, we review all of the public comments set to the Oregon PDAB each month. And based on some of the comments we've received lately, I want to clarify 3 things about our process and mandate. First, the statute that created Oregon's PDAB includes really 2 equally important considerations for our affordability reviews. One is patient costs, and the second is system costs. The Oregon PDAB has a dual mandate for our affordability determinations as described in the Oregon Revised Statute 646A.694. That statute charges the PDAB to identify drugs that may create affordability challenges for healthcare systems or high out-of-pocket costs for patients in this state. This means that the PDAB is looking at challenges for both patients and for healthcare systems. And some drugs may cause greater challenges for patient out-of-pocket costs, while other drugs may cause greater challenges for healthcare systems. And of course, some drugs could cause challenges in both areas. So, that dual mandate is important to keep in mind. Second, the Oregon PDAB is still new and continuing to develop and improve our processes for collecting data and conducting these affordability reviews. This means that our processes for conducting these reviews will have changes each year within the structure established by our administrative rules. Some of our review processes and timeline is different this year compared to 2025, and I fully expect that we will make additional changes in 2027 to build on the lessons we learned this year. We expect changes each year as we continue to develop and refine our processes. And of course, the board may choose to focus in different areas from one year to another. So I just want to make sure folks understand that we are going to continue to iterate. And third, we've received a lot of comments about the Oregon PDAB policy related to reviewing drugs that have orphan designations from the FDA for the treatment of one or more rare diseases or conditions. Again, I want to reiterate that the PDAB Administrative Rule 925-200-20, Section 2N, apologies for the hard to follow citations today. That administrative rule section specifies that a prescription drug approved by the FDA for other indications, in addition to a rare disease or condition, is not exempt from affordability review for those other indications. The board has discretion each year to make decisions about where to focus our drug review efforts among all of the drugs reported to DCBS. In 2025, the board decided not to review drugs with orphan designations that also had FDA approvals for other indications. In 2026, the board decided that there would be a public benefit to including some of these drugs approved for other indications in the review process. This year-to-year change reflects the board's responsiveness to changing situations and also improvements in our data analysis capacity. And I want to remind folks that the board has discussed the policy and the process related to orphan designations of drugs in multiple meetings, including recently April 2026, January 2026, and last year in March 2025 and February 2025. We've received recent comment letters that include reference to out-of-context statements made by board staff in the March 2025 meeting, and I want to encourage interested parties to review the complete and robust discussion that the board had last year in both February and March 2025 about drugs with orphan designations and about our limitations around data analysis capacity in that year. As I previously noted, we continue to develop and refine the PDAB processes to better support the board's work and enhance our capacities, which can lead to changes in the future. So want to make sure folks are aware of that context. And with that, are there any questions from the board about staff's current work or our program updates? Chris?
Yeah, first, I just wanted to say thank you to you, Director Young, and Lou for facilitating the community engagement sessions. The one I was at, it wasn't the best attended, but I felt like we had some really good discussion. And so the question I had is, there was a pastor, Mark Jackson, who was on the call that I was on, who brought up some ideas on ways to engage with maybe some some underserved communities and get more engagement and involvement in future years. And the question I had is really, how is that something that the staff are interested in doing, and are there ways, not for this year, but in future years when we're doing those community engagement sessions, to maybe use some of those ideas that the pastor shared with us, or engage with local community leaders before we develop the implementation strategy for the engagement, to maybe get more engagement from the communities in the future years?
Yeah, we're definitely doing some thinking about lessons learned from this year's community forums, and how we can maybe shift tactics a little bit to approach that differently in the future. Yeah, I heard Pastor Jackson's suggestions. That might have been our very first session, actually, along with you several weeks ago. And that's one thing we've been talking about with everyone who's participated. Just Monday at the Beaverton Library, we had a good conversation with a person who's part of a lupus patient support organization about how we might be able to work with groups like them and make additional contacts with patients who are dealing with, especially the challenging and complex diseases. And I think one of the things that we're going to look for more opportunities in future cycles is, how can we find ways to do a better job of joining existing events and going to where patients already are. It's a lot to ask people to take time out of their lunches or their evenings on a beautiful spring evening to spend it on Zoom or spend it in a library meeting room. And so looking for ways that we can meet people where they are and hear how that's impacting, how these drug costs are impacting their lives, is something we want to expand on for next year. So
I really appreciate that, sir. Thank you. We had the unfortunate timing of it was game 5, I
last
think,
Blazers
of the
game, I
Blazers
think.
series.
Yeah.
Yeah.
There's always something.
Yeah.
So yeah, please keep, and board members, I invite, please keep sharing your suggestions with me and the team as well, about how we could approach our community outreach in different ways in future years. Board Member Murray.
Thank you, Sarah. I was also appreciative of having one of the legislative behavioral health and healthcare committee members at the session that I attended. I thought that was tremendously informative, and I would encourage that we extend an invitation to the committee every year, letting them know, because they bring a lot of, their growing experience is good to have, and they need to hear the things that challenge the PDAB board too, and from the patients, so directly. So anyway, I was appreciative of Representative McIntyre being at the meeting. Thank you.
Yeah, very much so. And we, appreciate Representative McIntyre taking time to join us. Appreciate some of the other legislative staff who attended some of the sessions. So again, always like to have more people, but we learned some good things from the people we heard from. Anything else? thank you, everyone. Again, thank you for your participation as well, board members. And with that, Vice Chair Hartung, I'll turn it back to you.
I had a comment, Director Young, about our the feedback that we received throughout this process, is that going to be synthesized and
Yes.
disseminated in some sort of structured way?
Yes, we're working on a summary report, and my goal is to have that ready by next board meeting.
Okay. Another thought before we move on. Are there, and this is kind of this aligns with what Board Member Murray was saying about other having input from other boards, it sounded like, in the state. And I don't know, you probably more aware of this. Are there ways that we can engage with other healthcare related boards that the state has endorsed or is kind of operating with, such as the Health Evidence Review Commission and the HERC and their work? And I don't know if they engage with the public at all in their deliberations, but is there a way to kind of leverage kind of what other folks have done and learned? And we maybe already been doing that, but I just wanted to ask about that.
That's a good question. I'm not sure. I'm not aware of current processes for doing that, but it certainly doesn't mean that we can't or shouldn't, and definitely worth having some conversations and some exploration about if there's ways we could more directly engage with some of those other boards beyond just reading each other's reports, which we certainly can and do.
Yeah.
Yeah, I'll take that back and we'll investigate further.
Yeah. Okay. Great. Thank you for that update. Appreciate.
Thank you, everyone.
Okay. The next item on our agenda is public comments. And so today we have two public comment periods. The first is for public comments about general topics, and the second period will be used for comments about the prescription drugs under board review for this next cycle. The board received 6 letters about general topics, and the board received 9 requests to speak about general topics. So the letters that we received, which were posted with the agenda items, I'll just read those for the record. We have a letter from Carolina Summers from the Rare Disease Network, Jennifer Irby from Beaverton Pharmacy, Daria McGrew and Alexandria Hussey from Pharma, Patricia Pomeroy from Padala Farms, Gail Lovelace Manasco, an individual who lives in Bend, and Tiffany Westrich Robertson from the Each Pick Coalition. So those letters are posted in the agenda items. And then again, we received 9 requests to speak about general topics. I will call on those who sign up to speak and ask them to state their name and their organization. Afterwards, I will invite anyone from the audience who would like to speak on a general topic to use the raise the hand function on Zoom. Because we have a little bit more time in this particular meeting, we're going to be allowing speakers to have 5 minutes to talk about the issues that they wanted to discuss. And so Melissa is going to keep time. And so I'll just ask her to raise her hand in the Zoom function to let me know when time has expired. So with that, the first person that we have on our list
Could I, yeah, go ahead, sorry.
Yeah, go ahead. Yeah, Chris, did you have a comment?
Well, I just had a question, Dr. Hartung. Because we are in a more open forum today, usually the board does not interact with speakers, but is the intent to be able to ask questions if we have clarification or questions about what the public person is presenting or asking?
Yes, so I think because we have more time today, we are going to give ourselves the latitude to, if we have follow-up questions or comments, we are allowed to do so.
Thank you.
Was that your question as well, Board Member Murray?
Yes, it was. Thank you.
Okay. All right. So yeah, it's a little bit different, but this is great that we have more time to spend on these today. So so with that, the first person that we have on our list of individuals to speak is Joel Nista, who is coming to speak on Zetia, Crestor, and the Medicaid program. So is Joel queued up to talk?
Yes, Joel should be able to. Joel, you should be able to use your mic and camera right
Hi,
now.
can you hear me okay?
Yes.
Oh, great. So I'm trying to figure out how to turn my camera on, but I don't see the option here. Interesting. Oh, hang on a second. I think I know why. Thank you for your patience. I appreciate it.
Typically, it's in the lower left.
And for some reason, it's wanting to use my phone. So here I am. Thank you. See if I can get this dialed in so I look semi-normal. Okay, I'll do that. Good morning, everybody. So I just wanted to say that I'm newly retired as of the end of the year, beginning of the year, I should say. And I've been taking cholesterol medicines. And at the time, I was just fortunate that I worked at companies that had really good healthcare. But I always watched the retail price of the medications that were going up and down on one medication to about $325, $350 a month, and it would go up and down, kind of following the stock market because they were for-profit healthcare companies selling the drugs. So I've noticed after I retired, I actually pay a little bit more for healthcare now. And you have to be super careful about what you have done and how much Medicare is going to pay and if your secondary is going to pick up the rest or not. So I just want to make general comments about this. I also look back at companies that I worked for that I had great healthcare with, and I realized a lot of these companies with great healthcare were paying on my behalf something like $2,000 a month to have a healthcare package for me. And I thought that was just totally outrageous. And then I started looking into things about healthcare and why they were so expensive. So I just want to make comments about that. And I think overall, I think healthcare that's being guided by a for-profit industry is, I don't know. It's like it's immoral and it's discriminatory. So I'm hoping at some point in time we actually start viewing a single-payer healthcare where there's maybe co-pays or something like this for everybody in America who's an American citizen. That's all I wanted to say. And I appreciate the fact that you let me say this. And I follow Senator Wyden and what he's doing. And I know all the Democrats and some Republicans are really working very hard to protect our Constitution. So thank you so much. Thank you for letting me speak too.
Okay, great. Thank you. Any comments from the board? Okay. The next person on my list is Tiffany Weistrich Robertson from the Each/Pick Coalition.
Yes, hello. Thank you. So thank you so much for the opportunity to testify today. Again, Tiffany Weistrich Robertson, speaking on behalf of ensuring access through collaborative health and the Patient Inclusion Council. It's a two-part coalition that unites patient organizations and allied group on the Each side and a novel patient and caregiver coalition on the Pick side. We advocate for drug affordability policies that benefit patients. We appreciate the board's continued work on affordability issues and the opportunity to engage in the process. As you move into the 2026 review cycle, we strongly encourage the board to place patient experience related to their out-of-pocket medication costs at the center of both affordability determinations and policy development. As you are aware, our coalition recently completed an 18-month robust patient-reported affordability and unaffordability study, which collected open-ended responses from 537 individuals who are taking, have taken, or prescribed but unable to take a prescription medication. Again and again, the patients pointed out not the retail drug price, but insurance-related barriers, including insurance-driven high out-of-pocket costs as their true barriers. Importantly, 1/4 of all the 537 patients reported paying multiple prices for the same drug over time, similarly to the testimony we just heard, depending on insurance changes or plan design. The research team defined this as out-of-pocket cost shifting, which extended far past just the 1 calendar year we expected to see, because people reported it for the lifetime use of their drug. It was found accidentally as we were attempting to find patient-reported affordability and unaffordability threshold, what becomes affordable and unaffordable. And we were shocked at how many people actually experienced this over a long period of time. Of those, 51% labeled one or more of those out-of-pocket costs as both affordable and unaffordable, flip-flopping affordability for the same person using the same drug based on insurance changes and formulary changes. The research team labeled this affordability shifting. 15% of those volatile shifts, reporting sometimes 0 to 10, sometimes 1,001 plus when the formulary shifted and they no longer had access. That led to access shifting. So when they were no longer able to access that, that was largely due to switching insurers, changing insurance plans, high out-of-pocket deductibles, maximums, inability to apply financial assistance. Given that patients access affordability relative to their essential monthly budget, even modest cost increases obviously are going to impact their out-of-pocket costs and their affordability rating. These findings matter because they reinforce a critical point. Policies focused primarily on price may reduce spending somewhere else within the healthcare system, but they do not focus on improving out-of-pocket costs for patients. You can't have both. These findings also demonstrate that a UPL, which is designed to benefit payers, not patients, is not the right solution to serve the board's goal to help Oregonians better afford their medications they need. We know from discussions throughout the cost review process, this is a point of many of the board members are in alignment. In saying that, we understand Oregon has a dual role, also considering the drug causes affordability issues outside of patient needs, but we encourage the PDAB to thoroughly consider any solutions aimed at non-patient centered reform to ensure targeting that avenue does not harm patient affordability or access. We encourage the board to continue to prioritize other more patient-focused policies, such as in part any recommendations at the conclusion of a cost review process, and we applaud the board for including in last year's report 2 very patient-focused reforms, patient out-of-pocket cost caps and point of sale rebate pass-through. Both of these reforms directly address patient-identified obstacles to affording their medications. Lastly, we do want to raise concerns regarding the board's inclusion of drugs with orphan drug designations in the 2026 review process. We did state more about this in our letter. We believe the approach circumvents the board's statute. The purpose of these protections is clear. Patients using orphan designated therapies often have limited or no alternative treatment options. The policies that jeopardize stable access to those therapies can carry serious consequences. We strongly urge the board not to proceed with reviews involving orphan designated drugs for the simple fact of unintended consequences that we may not be able to see. At the end of the day, policies intend to improve affordability should be evaluated based on whether they actually reduce patient hardship and protect access to effective treatment as a priority, even if non-patient affordability is also reviewed. That requires starting with patient experience and ending with solutions that ensure patients can afford and access the medications they need. Thank you again for your time and consideration in these comments.
Great. Thank you so much for sharing that. I had just a question. This report of the affordability issues experienced by individuals in these 500 patients, is that something that can be accessed in your written materials that you submitted? Or
Absolutely. I believe we did send a full report in a letter, but I'm happy to resend that again. It is published on our website. It's a 2-part study. It was over 18 months. We did a pilot that was published in August of 2025. And then based on that, we did in 2024. And based on that, we did a full study where this time recreated the questions based on lessons learned of what worked and what didn't, because part of it was to help PDABs in existing question design, patient-facing question design, and uncovering the missing why. So there were a lot of open-ended and just recreated the questions on lessons learned. But both of them are published on our website, and we actually also have created a slightly revised version, just as an FYI, on again lessons learned that is currently being peer reviewed by a variety of professionals in the cost effectiveness world, and that will be available as a toolkit for PDABs to reference in patient-facing data collection for prescription drugs.
Okay, great. Thank you for clarifying that for me. Board Member Murray, did you have a comment?
Yeah, I did. I wanted to reiterate that I have to agree that what we see on a daily and weekly basis as far as patient affordability, so much of it depends on plan design, and those plan designs that change. You know, we just not too long ago went through a first of the year change. Many people changed either Part D plans or their commercial or employer plans changed. We have, you know, new formularies that show up, and you're exactly right about medications that have been affordable for years suddenly are either not on the formulary or their tier level has changed, or new therapies that they cannot get, have to go through multiple hoops of prior authorization or demonstrate use of other agents before they can even try the one, maybe even the one they've been on, because they've changed their insurance plan. We see this all the time, and it will be a focus of mine on affordability reviews this year of plan design. To me, it points out to the machinations behind the scenes of rebate and other activities that I don't particularly care to see that manipulate the price of the drugs to the patient. We can talk about system costs, but system changes happen and we have no control over them, in my opinion. We don't even know the objective information to make in some cases a decision on or a judgment on affordability of a medication, in my opinion, because we don't know what the true costs started out being before it works through all the different middlemen involved. So yes, but from a patient point of view and from insurance design, plan designs, I will be watching that and asking more questions about it. So I appreciate that feedback. Thank you.
Board Member Lehman.
Yeah, thank you, Tiffany. I always appreciate your thoughtful presentations and testimonies to us as a board. I appreciated your call out of the out-of-pocket caps and the other policy recommendations that we had. Do you, as an expert in this field, have other recommendations for policies that the board should be researching and learning more about as we go through this year and work toward that final report where we're going to have policy recommendations for the legislature?
We absolutely do, and I'd be happy to follow up as well. One of them including delinking with PBMs and several other policy reviews. We have it actually outlined in concordance with the research publications, so it extends from here's our findings, here's a result of what we believe are the right directions to go. So I am happy to provide that information.
Okay.
After.
That's great. If it's in the report, I need to read that report, but we will reference that and then reach out if I have any questions. Thank you.
Absolutely. We're here to help. Thank you.
Okay, the next person on the list for public comment is Lee Bliven from AARP.
Can you hear me?
Yes.
Good morning. My name is Lee Bloom II. I am, excuse me, I've got allergies, so I'm a little hoarse this morning. Yeah, I am a retired senior living in Oregon. I am both representing myself and my wife and AARP, Oregon, an Oregon volunteer, to share my family's experience. AARP is fighting for affordable prescription drugs in Oregon, so no one faces the impossible choice between buying medications and paying for food or housing. Excuse me, I'm all stuffed up. Basic needs are very essential, and like groceries and utilities. Oregon should not have to choose between paying for groceries or gas or paying for the medications. Well, medications can be different between life and death. It doesn't work if you can't afford it. The truth is, big drug companies use research that is funded by our tax dollars to develop new drugs. And then they charge us more than anyone else in the world to buy the the same drugs. Big drug companies are making billions while taxpayers are getting ripped off. That is why AARP continues to urge the state to stop big drug companies from charging Oregons 50 plus, the highest price in the world. A little bit about me. I'm retired and disabled, and my wife is a Cowlitz elder, retired, and is also disabled with dementia. We are one of the lucky ones. I can afford my health insurance and most of my medications. My wife has got OHP with extra help from the Cowlitz Indians to pay for her drug costs. My wife's drug costs, as of the 1st of April, were the plan paid $11,981. Others, especially the Cowlitz Indians, paid $3,842. For the 3 months, that was $15,823. That's a lot of money. We didn't have the extra help through the Cowlitz Indians and other resources. We'd be choosing between paying for medications and eating. We got, like I said, we are the lucky ones. We have the extra help, but I know people very close to me that have cut drugs in half, skipped dosages just to make ends meet so they can afford food on their table. Well, people need to have the choice of being able to eat, sleep, survive, and not have to worry about the cost of medications. I want to conclude with testimony by sharing AARP's priority recommendations for this board. Oregon has the opportunity to make things simple and more affordable for people at this time they're more important than ever. First, empower the board, set fair payment limitations for drug bases on price of other countries, while the Medicare negotiated maximum fair price, ensuring affordability for all payers in the state. Second, consolidate and maximize buying power across the state. Our agencies to negotiate lower drug prices. And finally, allows consumers to save money by updating Oregon law to make it easier for pharmaceutists to substitute less expensive biosimilar drugs for biological drugs the same way generic drugs are substituted for brand name drugs. Thank you.
Thank you, Mr. Blyven. Does board members have any comments or questions for Mr. Blyven? Okay. Thank you again. Appreciate your comments.
Thank you.
The next person on the list to speak is Lauren Sand from the Caring Ambassadors Program.
Good morning, everyone. Lauren Sant here, Caring Ambassadors Program. Really appreciate your time. Thank you for letting me speak, and thank you for all the work that you're doing. I really appreciate it. I am a member of the Each Pick, so I am not going to repeat what Tiffany had to say. I agree with everything she said, and I encourage you to read the reports. We have referenced it in probably almost every testimony that we've put in the last year with a link to it. So please do read that report. It's quite enlightening. And I also want to point out that last week, or this week, actually, in the board meeting in Beaverton, one of our distinguished medical clinic owners of our community pointed out the exact same issue of access switching, where they were on a drug, his wife is on a drug, and they got a notice in September that it's going up dramatically because it's no longer on the formulary at their insurance company. So this does happen all the time. I think we all have experienced it. I know all the pharmacists on this phone call have experienced it. So just wanted you guys to keep that in mind. I wish I knew I had 5 minutes. I used to my regular 3. Probably won't take it all today. I did attend all the board meetings except for the one in Redmond. They were unfortunately not well attended. I think it points out just how hard patient engagement is. And while I agree with the pastor that spoke that we need to do a better job of reaching to the underserved communities, I'm still not sure that they would show up because as was pointed out in the meeting on Monday again, for patients to show up in front of a board, in front of the state at this time, and with the policies that are happening right now, it's really difficult for them to put a face to it and a name to it. They are scared and they're not willing to testify. So my recommendation, as lessons learned and looking at other PDABs, since Sarah has mentioned that you guys do look at what other PDABs are doing, I would really suggest that we put together a patient engagement board to help you guys, and not one person. We don't encourage you to put one patient on the board because they're going to have a bias one way or the other, but put together a board that can help you, several from cancer, several from chronic disease, several from autoimmune, maybe mental health, definitely mental health, behavioral health. Let's put together a board that can really help you guys to understand where the patients are coming from. And finally, I really feel like Oregon deserves a patient or an insurance transparency board, similar to what you guys are doing for prescriptions. Let's have an insurance transparency board, and hopefully that could be a recommendation that you put forward in your recommendations this year to the legislators. And finally, I do want to thank you for the recommendations that you did put forward to the legislators, cap the copay and share the savings. I'm hoping that we can take one of those and make that a reality, although I'd like to see it a reality for all drugs, for all of grenades, and not just the 4 drugs that you guys looked at. So I really appreciate your work. Let's work together. Let's figure out how to make this happen. Let's figure out how to get you the voices from patients that you're not hearing. And again, I know that those meetings were a lot of work, and I really appreciate Lou and Sarah and all the board members that came to the meetings. It showed, and appreciate that. So thank you. Happy to take any questions and look forward to working with you this year. Let's really just keep patients in mind. Thank you.
Great, thank you. With no comments or questions, I'll just move to the next person on the list. Primo Castro. Oh, I'm sorry. Derek Flowers is the next person on my list from Value of Care Coalition.
Well, good morning. Thanks, Vice Chair Hartung, for the opportunity to comment. I'm Derek Flowers. I represent the Value of Care Coalition. We're a network of patient, healthcare provider, and caregiver organizations. We appreciate the opportunity to continue our engagement as this board makes decisions that impacts patients and their access to care. Last year, the coalition raised concerns early about the pace and scope of Oregon's drug reviews. We said that a process that prioritizes haste over rigor risks eroding public confidence and its outcomes. The board heard those concerns and others related to patient costs and risk to access, and it responded. The final review list was narrowed. The board voted against recommending upper payment limits, and the annual report centered on recommendations that reduce patient out-of-pocket costs, a goal we share. So we offer today's comments in the same spirit of constructive engagement as the board prepares to begin its second full review cycle. First, on affordability. After a full review cycle, I don't think the board concluded its work without arriving at a shared, I think the board did conclude its work without arriving at a shared definition of affordability. And it's not a criticism, it reflects the genuine complexity of the question. But keep in mind that question will still be at the center of each review conducted this year. As the board prepares to begin again, we'd welcome clarity on how it intends to approach that definition, what criteria will anchor it, and how those criteria will be applied consistently across a list that spans cancer treatments, immunology, diabetes therapies, and drugs that treat rare diseases. A transparent affordability framework should be established before reviews begin, rather than developed alongside them. Secondly, on therapeutic alternatives, the board's subset documents list therapeutic alternatives alongside each drug under review. We've raised concerns about this before, and the 2026 list sharpens them. For a number of drugs on this year's list, the alternatives identified don't always match the drug reviewed indication for indication, as you might expect. They may share a therapeutic class or treat the same broad condition, but at the level of specific patient populations, disease stage, or clinical context, the comparison sometimes breaks down. When a drug's the only approved option for a particular indication and its listed alternatives simply don't cover that ground, or when a drug treats multiple commonly occurring comorbidities and its alternatives don't, calling them alternatives overstates what they actually offer. And this matters because affordability analyses built on these comparisons inherit the problem. If the comparator doesn't reflect the clinical reality, then neither does the conclusion. Patients and the clinicians who treat them know this firsthand. A drug that works for one patient's specific circumstances isn't interchangeable with one that doesn't. So we urge the board to scrutinize carefully whether the listed therapeutic alternatives are genuinely substitutable for the populations actually being served, and to be transparent about where they fall short. And third, on drugs with rare disease designations. Some of the drugs listed on the 2026 list are flagged with the asterisk indicating they carry a designation for a rare disease or condition. Oregon statute and rule speaks directly to how drugs like these should be treated, and we know the board has been working through what that means when a drug also has other approved uses. The challenges aren't just statutory, though, they're also practical. These drugs are widely used. They don't treat one condition in one kind of patient. Their value to patients, to doctors, and to the health system comes from the full picture of what they do. Trying to review them one slice at a time, setting aside the rare disease indication and focusing only on other uses, means you're not really seeing the whole drug. And if you can't see the whole drug, it's hard to say what it's actually worth. And if that's the case, how can you make judgments on cost, value, and affordability? How will the process ensure that patients relying on these therapies for rare conditions aren't caught up in affordability determinations that weren't really designed with them in mind? And this connects directly back to the therapeutic alternatives challenge. Many drugs on the list don't have alternatives that match their indications across all their uses, but the gap is even starker for rare disease populations who may have no alternatives at all. It's not a minor detail, it's a fundamental gap in the framework that highlights the nearly unmanageable complexity of your task, but it has real-world consequences for the patients who have nowhere else to turn. The patients and providers who depend on these drugs deserve a process that answers these questions before it reaches conclusions on how affordability will be defined, on whether comparators reflect clinical reality, on how rare disease populations will be treated, and on whether the framework can accommodate drugs whose value cannot cleanly be separated from the full range of conditions they treat. So we urge the board to resolve these questions before the reviews begin next month. Thank you for your time, and thanks as always for the opportunity to comment.
And Vice Chair, this is Primo Castro. Apologies, I stepped away for a few minutes, so happy to provide my oral comments after you're done.
Okay.
With questions. So.
Okay. 1 second. You're next on the list, but let me just see if we have any. I don't think there are any comments or questions for Mr. Flowers, but if so, we can address those now.
All right. Thank you very much.
Okay. Great. Thank you. Appreciate it. Okay. Primo Castro, you are next on the list from Bio, so you have the floor.
Great. Thank you very much, Vice Chair and members of the board. Primo Castro with the Biotechnology Innovation Organization. And just so you know, my internet has been a little bit unstable, so I'll keep the camera on as much as I can. Bio reiterates its concerns around the board selection of orphan drugs for the preliminary list, which is in clear conflict with the PDAB statute. The statute explicitly exempts orphan designated drugs from affordability reviews as it recognizes the importance of the orphan drug exemption and the need to maximize protection for rare disease drugs. As Bio has previously commented, the PDAB must implement the orphan drug exclusion as intended by statute to be maximally protective of orphan drugs. In recognition of the unique need to maintain incentives for developing new therapies targeting rare diseases affecting countless patients, orphan drugs treating multiple orphan conditions have become an important part of meeting unmet patient need. IQVIA data from 2020 show that since Congress passed the ODA in 1983, the FDA has granted 838 orphan drug indications to 564 distinct drugs, meaning hundreds of drugs carry multiple orphan indications. There are over 7,000 known rare diseases and approximately 30 new ones are identified each year. While each rare disease affects only a relatively small number of patients, collectively, over 30 million Americans are affected by a rare disease. The federal government has an extensive existing policy structure intended to support innovation and investment in orphan drugs and conditions for which patients are desperately waiting for cures and treatments. The Oregon PDAB cannot risk undermining the important incentives provided at the federal level to support rare disease innovation. Preserving incentives to develop orphan drugs is also critical for the United States to maintain its leadership in biomedical innovation. Recently, China has announced that it will, for the first time, grant orphan drugs 7 years of market exclusivity. Given this development, it is critical to preserve American competitiveness by ensuring that the incentives for developing orphan drugs remain robust. The PDAB must implement the orphan drug exclusion to be maximally protective of orphan drugs, in recognition of the unique need to maintain incentives for developing new therapies targeting rare diseases. Thank you.
Thank you, Mr. Castro. Board Member Lehman, did you have a comment or question?
Yeah, I had a question for Primo. Primo, are you still able to be on and take a question?
You know, I am on. I took off my camera just because.
Yeah, no problem.
Yeah.
As long as you can still hear me and respond. I had a question about the orphan drug approvals that you just mentioned. Of the 800 and some approvals, I didn't catch the exact number, but do you have information on the number of those drugs and approved uses where the drug was approved specifically and only for the orphan drug indication? And how many were already existing branded drugs where the pharmaceutical company got an additional approval for an orphan drug indication to extend the patent life of the branded drug?
Mm-hmm. Yes, so Board Member Lehman, so I think you mentioned, so the total number that I mentioned is 838 orphan drug indications to 564 distinct drugs. I don't have that information, but I'm happy to follow up with you, follow up and provide the information to staff a little later.
Yeah, I think the way it's presented is that the drug companies are doing this research for these orphan indications that would never have drugs to be used in them. But it's been my experience that it's usually most commonly drugs that are already big sort of blockbuster drugs for the pharmaceutical companies that end up with these orphan drug indications to extend the patent life. So I'd be really interested in having a response to that.
Mm-hmm. Absolutely. Thank you.
Okay. The next speaker on my list here is Laura Packard from Voices of Healthcare Action. Good morning, Laura.
Hello.
Ms. Packard, floor is yours.
Thanks. I'm Laura Packard with Voices of Healthcare Action. We're a nonprofit organizing adults with serious medical conditions and healthcare activists to make healthcare in America more affordable and available for all. I'm representing 3,567 Oregonians, some of which have shared their stories directly with this board over the past year. Patients know that drugs don't work if people can't afford them. Too many Oregonians are priced out of their medications, and our lives are on the line. In 2024, roughly half of the Oregonians from the Alterum Healthcare Value Hubs survey reported being somewhat or very worried about affording the cost of prescription drugs. That's half of the correspondents. We know prices for patients have not improved since then. Thank you for all the time and effort you've put in so far in reviewing drug affordability. And now it's time for the board to start taking action by moving beyond the review process to doing something about it, including setting up our payment limits to make high-cost drugs more affordable for all Oregonians. And please keep listening to patients because we can't afford our medicines. Thank you.
Thank you, Ms. Packard. Before you go, I think we have a comment from a board from the board. Board Member Murray.
A question, Ms. Packard. What was it study that you referenced? If you don't mind, can I get that name again, please?
Sure. It is the Alterum Healthcare Value Hubs Consumer Healthcare Experience State Survey from 2024. So it's a little bit old, but still pretty recent.
Is there a chance that maybe that could be sent to the PDAB staff that they could forward on to us to look at?
Sure. I'll see if I can find it and I can even put it in the chat.
Okay. Thank you.
You're welcome.
Okay, with no other comments, we'll move on to the next person, which is Chris Coughlin from the Oregon Consumer Justice. Ms. Coughlin, you have the floor.
Great. Thank you very much. Good morning. My name's Chris Coughlin. I'm the Federal Policy Director with Oregon Consumer Justice. I appreciate the opportunity to share some comments on behalf of Oregon Consumer Justice with the board today about the impact of prescription drug prices on consumers. OCJ envisions a vibrant future where all Oregonians live with dignity and abundance and experience health, joy, and economic opportunity. We work to make financial and business transactions reliably safe and support Oregonians in knowing and exercising their consumer rights. We appreciate the board's work reviewing data and gathering information on how drug affordability and accessibility are impacting consumers, and appreciate the comment from the executive director earlier today about the requirement for the board to balance the impact of costs on the overall system, as well as the impact on consumers and patients. As we navigate the complex issue together of rising drug prices and the ongoing struggle between insurance companies and big pharma in this space, we can't lose sight of the immediate needs of those living with healthcare needs and their growing concerns about overall affordability, but especially including the cost of prescription drugs. Recent polling from health policy researcher KFF reports that the cost of prescription drugs prevents some people from filling prescriptions. About 4 in 10 US adults say they have not taken their medication as prescribed in the past year due to costs. This includes 3 in 10 who say they have taken an over-the-counter drug instead of getting a prescription filled, a quarter who have not filled a prescription, and 1 in 5 who have cut pills in half or skipped doses of medicine because of the cost. KFF found that larger percentages of lower income, those who are uninsured, women, Black and Hispanic adults report taking these measures to try to cut the costs of their prescription drugs. Every Oregonian deserves to receive equitable health care. When we support and promote accessible, transparent, and ethical healthcare practices, individuals and families have the chance to experience well-being and contribute meaningfully to their communities, building a stronger Oregon together. Oregonians deserve clear, accurate pricing information to make informed financial decisions so they can understand and explore their options. We've already heard today about changes in formulary and how that shifts things for people, and it's all of a sudden they're in a new situation. Transparent pricing practices and internet interactions with pricing, such as copays, out-of-pocket maximums, and other insurance processes, are particularly important in the prescription drug space. According to KFF polling, there is broad bipartisan agreement that the government should be playing a bigger role when it comes to regulating prescription drug costs, with at least 2/3 of Republicans, Democrats, and independents saying that there is not as much government regulation as there should be in this area. OCJ believes it's time for policymakers to prioritize the needs of patients and take action to ensure they have consistent, affordable access to the medications they need to maintain their health and well-being. Thank you for your consideration and your service in building the future that Oregonians deserve. And thank you for this opportunity to comment today.
Great. Thank you, Ms. Coughlin. Appreciate it. Okay, the final person on my list to speak is Charlie Fisher from Osprey.
Good morning, members of the board. Thanks for giving the opportunity to speak today. My name is Charlie Fisher. I'm the state director at OSPRG, the Oregon State Public Interest Research Group. We're a statewide grassroots independent, so we don't take any money from any companies that are in the healthcare system, organization that is focused on bringing down healthcare costs for consumers. And first, I just wanted to say I attended one of the public forums that was organized. And I just want to thank you all for the work that you did to make those happen. I think it's so important to get out in the community and hear from regular people about their experience in this space. We have obviously heard a lot from our own members and from members of the public about the problem of high drug prices, and both kind of anecdotal as well as we've done surveys of the public. And the surveys, I mean, basically all of that tracks with what you've already heard. People, about 1 in 6 Oregonians from a survey that we did in 2024 said that they had skipped a dose because of the cost. About 11% said they'd simply not purchased a drug because of its cost. And much larger percentage of Oregonians, 3 out of 4, said that the overall cost of healthcare was a concern for them. And while there are many reasons for high healthcare costs, it just is the fact that high and growing drug prices play an increasing role in the overall cost of healthcare for people, because they have to pay higher premiums. Their deductibles are higher, and therefore they have to pay more out of pocket. And then just, the taxpayer money that's going towards paying for these drugs. So really everyone is affected in some way by the high cost of drugs, even if, they are lucky enough not to need some of the drugs that are the most expensive. Speaking to individuals over the years, the biggest theme, just looking through kind of the things that people say to us, is focused on high copays and other out-of-pocket costs. Several mentions of hundreds or thousands of dollars for a month's supply of drugs. And this was for both people who had insurance coverage and those who didn't. We heard a lot of mentions of autoimmune drugs, migraine medicine, antidepressants, cancer drugs, people talking about skipping prescriptions. And one thing that just really stood out to me was we had one woman said that anytime someone in her family gets prescribed a new drug, she loses sleep over her ability to afford those prescriptions. So, this is having real impacts on people in the state. We would just, so again, want to thank you all for the work that you are doing to really think about these issues and take them seriously and really dig into the data. A couple just things that are happening in other states that might be of interest. The Maryland PDAB just recently set a UPL on Ozempic. And it's estimated that when that goes into effect for the whole state, the way that it works is it phases in for state and local governments, and then a year after that, it can go in effect for everyone. The estimate is that it'll save about $164 million a year in drug spending. And I'll just note, obviously, prescription drugs are not the only problem in the healthcare space. I will say that in the insurance space, there is rigorous review of their premium increases, at least in the commercial market. And to the extent that states want to do something around like actually setting an upper payment limit, and this is what Virginia did, although unfortunately it was vetoed recently. You can directly write in that saying insurance companies have to, in the rate review process, account for savings that they have accrued as a result of something like an upper payment limit and direct those savings towards, I would say, first, bringing down out-of-pocket drug costs for their patients, but then just overall bringing down costs. So we can really say you can't just keep that money as profit. You have to put it back into the system and ideally bring down costs for consumers. The last thing I'll say is just to give a brief answer to the orphan drug question. I know drugs like Humira and Crestor, two just huge blockbuster drugs focused on rheumatoid arthritis and cholesterol, later gained orphan drug designation. So I think just important context to have that completely exempting all orphan drugs would be exempting some pretty significant drugs that have big impacts on people in terms of the cost and just in terms of system cost as well. And finally, I would encourage you all to take seriously the prospect of recommending to the state being given additional authority to set an upper payment limit. I think a way that is a little bit more elegant or easier than trying to come up with what that UPL number is just basically adopting what the Medicare fair price is. That the federal government has already done that work for you. And it just makes sense that not just one segment of the population should be able to have the benefit of that. It should be something that the whole state should be able to benefit from. So again, thank you so much for your time. And yeah, happy to answer questions.
Thank you, Mr. Fisher. Board Member Hoagland.
I'm very pleased that we have so many advocacy groups speaking today, and my question to all of you is, how might we have done a better job to include your patients in our recent public forums? Because it feels like it would have been very helpful. They were small in number, and I just really want to use your brain space to figure out how we might outreach better.
Sure. Well, I guess since I'm on the floor, I'll give a quick answer. I mean, I think the reality is it's really challenging, just that like getting people to come out to things. We have organized events where we try to get people to come out and share information about their experience or just learn about the work that is happening. And it takes a lot of work, like phone banking and things like that. One thing that we found really effective, and I think Sarah mentioned it, is actually going to things where people already are. And so we had a lot of success. We did this thing we called a healthcare roadshow, where we went to neighborhood associations and senior centers, agricultural granges that were already meeting, and just kind of said, all right, here's what we have to offer. Tell us your experience. And that way we didn't have to convince people to come to something they weren't already coming to. So that's, as I've been thinking both about the public forums and then our own work and just getting in front of more people, that's something that we've found to be successful.
Okay, great, thank you. So why don't we, since we have time, I see Tiffany Westrich Robertson has her hand up, so maybe can we circle back to her? I'd like to hear what she has to say.
I wanted to answer that question with some thoughts. To everybody's point who's spoken, it is so difficult for many reasons. It's difficult anyway, because everybody's got their own personalities, right? There's like, I and others have no problem being in front of camera or talking to people, but you got to just personality, right? That's one block. But another one is, this is a really complex issue. People don't really quite understand what a PDAB is. And, and I've been watching all of the efforts around, in the patient engagement, in town halls and et cetera. And one of the things that we're starting to do at the Patient Inclusion Council, and we're happy to share successes, what works, what doesn't, similar to the question design, is we're going to try to flip the way that we're doing like town halls. We're actually going to start modeling our own town halls to see if we can help generate information for all of you, because it's patient-led or peer-led instead of government-led. So maybe just an ease of feel, like, oh, I feel safe here, kind of a safe environment. But we're going to start with asking people to share their experiences instead of leading with, here's what a PDAB is, here's what, and just make it about your experience and tell us what you need to happen. And most importantly, your why. So not just stop as, well, this is cost. Okay, well, why does it cost that? That's just really, really important. And also we'll be formulating some like focus group style probing questions that would be important, because you never know what somebody's going to say. So in order to keep them on some level of track where we can take away meaningful information. So that's possibly one. And as Charlie said, meeting people where they are is really important. But I think that we might have to consider flipping it and trying to really tap into patient-led discussions, because patients tend to feel safer when they talk to other patients. So that's just something I'd throw out there.
Okay. I think the board wants to re-recognize Ms. Packard for her comments about this issue.
Thanks. Just want to echo what Charlie and Tiffany said about going where the people are. And you can look at insurance companies sometimes have health fairs. Healthcare providers, hospitals may sometimes have community health fairs. So if you go into those places where patients are already going for basic checkups or questions about their health care, that's a great way that somebody else has done all the lifting and outreach for you.
Okay. Yeah, and I see, I also just want to echo what Lauren Sand said earlier, and she just popped in the chat box, that I think either as a function of this committee or some other separate committee pushing for some sort of patient engagement, patient affordability engagement board that can funnel and synthesize those concerns to us. That sounds like a really great idea that we maybe should look into. Board Member Hoagland.
Another thing I wanted to mention as a provider is sometimes the difficulty with the electronic medical record to follow what the patient experience at the pharmacy. You don't get the information when patients decide not to pick up medicines because of price. That's not something that immediately gets back to the person who prescribed the medicine, and that might be something also to look further at.
Certainly, yeah. All right, well, it looks like Chair Bailey has entered the chat literally, so I think maybe we can, if you're comfortable with taking over the reins of this meeting, move to the next part.
Yes, Vice Chair Hartung, thank you for pausing here at this point of the meeting for me to be able to help facilitate the next piece. I do wish to just pause while I pull up the meeting guide. I apologize for that. But moving forward to our next portion of the agenda, I believe, is making sure I'm following and I'm on track here. The next portion of our agenda is related to the second public comment portion for comments about the prescription drugs under board review. The board received 8 letters to specific to the drugs to review. Those letters were Jane Leo from the American Oh, Melissa, I see you have your hand raised, so I'll pause.
Oh, excuse me, Chair Bailey. We were going to see if anyone from the audience wanted to speak. It's after we completed the people that signed up. So
I
now it just
appreciate
be,
that. It sounds like
you.
I am on the wrong part of the agenda from coming in here in the middle, so I certainly apologize for that.
No, I
Thank you.
think, I mean, I just moved forward because I thought, given the hands that were raised, we didn't see any more hands. But yeah, if you want to pause for, yeah, and I appreciate, I apologize for just putting you on the spot. I saw
no
you
problem.
down there and I
No
was like
problem.
waiting for a time to transition. But yeah, no, we can pause if there are other comments from attendees. And Chair Bailey, if you want to take over, or I can continue, or because we're basically in this kind of interim period here.
Yeah, no problem. I mean, it's fine. We're moving to the portion of the agenda related to the letters we received about drug specific feedback. Is that accurate? Or I see
Well, I think we're still in the
in the first piece.
first
Okay,
comment
yep.
section.
I'm
Yeah,
happy to help
yeah.
advance our dialogue. Looks like we have a hand raised from Scott Bertani. So Scott, I see that you have your hand raised, so you have the floor. Thank you again, Vice Chair Hartung.
I appreciate that, and I apologize to be that guy at the last minute, but I did want to just make some comments based on the comments that Director Young had made around process framing, and just wanted to thank you. But I'm Scott Bertani with Health HIV, and we're a national organization that's focused on HIV prevention and care and aging and a lot of health policies that you're talking about. And I've had the opportunity to present to the board before, and I bring prior near 2-decade experience in HIV case management and HOPWA housing services and state HIV planning in Southwest Washington that included coordination with Oregon partners to really help people with HIV stay connected to care across state lines. And I just wanted to briefly build on Director Young's process framing, but through a patient advocacy lens approach, because I think, as you were said, it matters for how affordability review is understood a lot across these very complex and chronic conditions. So we really do appreciate the clarification that the board mandate includes both patient out-of-pocket costs and state system costs. And as the board really applies that mandate, we want to encourage it to look at access in two places. One, what patients and providers experience at the point of care first, and then what's happening upstream in the payment system secondarily in that respect. And I think that means looking at things like prior authorization, as you've mentioned, it's formulary placement, it's pharmacy access, and it's care coordination burden. But it's also accounting for, as you suggested, PBM practices and a lot of the rebate dynamics that kind of shape the real cost picture for patients and providers and public programs. And second, we appreciate that the review process is still being redefined, as you said, and that Oregon's approach, may inform other state PDABs. And as the board improves, I think its data collection and its feedback forms and summary reporting, we just want to encourage it to keep asking whether that data shows access friction, but not only just spending friction. And last, the board's focus, as you said, it changes from year to year, and it changes as policies also iterate across the country. And we do encourage a clear prioritization process within each drug review. And not every high cost drug creates probably the same access concern, and not every access concern shows up as a high out-of-pocket cost. So we just appreciate the board's openness and its process and its willingness to keep improving on it. And from Health HIV's perspective, I think that iterative work is where patient and provider input, as Lauren and Tiffany and all the others have suggested, can really be most useful, because affordability review becomes too focused on state budget concerns, I think would lose sight of some of these real world patient needs that come up. So thank you for your time, and sorry to be that guy.
No problem. Maybe there'll be more people that are stepping up to provide additional comments since you did. So thank you for sharing the additional feedback. Before we move into the drug specific public comment, do we have anyone else who would like to provide general public comments? All right, well, with me seeing no hands raised related to this section of our agenda, we'll now move forward to the second public comment portion of today's agenda related to comments on the prescription drugs that are currently under review. The board received 8 letters specific to the drugs under review. Those letters came from these individuals and organizations. Jane Leo from the American Cancer Society, Action Network related to Keytruda and Verzenio, from Susanna Masteris from the Community Liver Alliance on Keytruda, Tom Brownlee from Pfizer on Xeljanz, Helen Fitzpatrick from AbbVie on Skyrizi, Seth Grenier from the National Multiple Sclerosis Society on Ocrevus, Timothy Layton from Genentech on Ocrevus and Zolar, and from Terry Lee and Christian O'Neill from Merck on Keytruda, and from Michael Egging on the Rare Access Action Network on Keytruda. The board also received 1 request to speak today about drugs under review. I will call on the individuals who signed up to speak and ask them to state their name and organization. Afterwards, I will invite anyone from the audience who would like to speak about the drugs under review to use the raise hand function of the Zoom meeting to raise your hand if you would like to provide any oral comments. Speakers will each have up to 5 minutes, and during this extended public comment time on today's agenda, board members are welcome to ask questions of the speakers. So the individual who signed up today to provide some feedback to the board is Terry Lee from Merck related to Keytruda process-related comments. So Terry Lee, I see that you are here, so welcome and you have the floor. I do want to let you know, I believe you're on mute, so we are having audio problems related to hearing, and that may be on our end. We may have to configure your setting with audio. It appears we might be able to hear you now. I can still not hear your, Melissa, can we check on our end if we have any settings for the co-hosts?
I have made Terry Lee a co-host, so maybe, I'm not sure if it's a volume. It looks like your microphone is unmuted. We can see on your Zoom tile, but I'm not sure if it's a volume issue or.
Since we have some time in today's agenda, I think I'll move forward with letting others speak. And if you want to maybe Terry Lee exit and rejoin or something, maybe, but we will make sure that you have the opportunity to have the 5 minutes to present to the board today. So I am not limiting that opportunity. So maybe try to come back in.
Can you hear me now?
We can. Thank you. Welcome.
Awesome. Great suggestion. Thank you so much. And I'm just timing myself to make sure that I don't run over time. But thank you to the chair, to the vice chair, to the members and the staff. My name is Terry Lee, and I'm the Vice President of State Government Affairs and Policy at Merck. We appreciate the opportunity to comment on the Oregon Prescription Drug Affordability Board's decision to select Keytruda for an affordability review and refer you to our written comments submitted in advance of this meeting. At Merck, our goal is to help extend and improve the lives of people with cancer. We are extremely proud that Keytruda has helped to transform the way physicians treat some of the deadliest forms of cancer. Respectfully, the process for selecting drugs for affordability review does not adequately account for the significant clinical value of Keytruda and the important benefits it provides to patients. Today, Keytruda is foundational in the treatment of many cancers. In the United States, Keytruda has 44 FDA-approved indications across 19 different tumor types and 2 tumor-agnostic indications. In addition to the drug's substantial breadth of approved uses, Keytruda has demonstrated improved survival outcomes in 14 tumor types. Many of the 44 indications for Keytruda address high unmet need in small subpopulations or in populations with rare cancers. Limited treatment options in these settings are reflected in the 10 orphan drug and 16 breakthrough therapy designations that Keytruda has received. Our very first FDA-approved indication in 2014 was an orphan designation for the treatment of melanoma. Overall, the extensive clinical evidence, broad utility across tumor types, and meaningful survival benefits of Keytruda for certain indications reinforce its value as a foundational oncology therapy. Merck strongly opposes the selection of Keytruda for Affordability review as proceeding with a review of an orphan designated product conflicts with Oregon law and the patient protection purpose of the orphan drug exclusion. Any selection of a drug with an orphan designation, even if the drug is also approved for non-orphan indications, violates the PDAB statute, which expressly exempts orphan designated drugs from affordability review. The statute states that a drug that is designated by the Secretary of the United States Food and Drug Administration under 21 USC 360BB as a drug for a rare disease or condition is not subject to review under the PDAB process. The exemption for orphan designated drugs is a provision to protect patients, not merely a technical exception. We believe the legislature created the PDAB with guardrails designed to protect patients with orphan indications whose access and treatment circumstances warrant special care. That carve-out makes sense considering the federal orphan drug framework. FDA explains that a rare disease is one of affecting fewer than 200,000 people in the U.S., that many rare diseases are life-threatening, and that most do not have approved treatments. FDA further explains that orphan drug incentives exist because some rare disease therapies historically were orphaned or discontinued for lack of sufficient financial incentive, and because of the small size of rare disease populations makes drug development especially difficult. Against that backdrop, Oregon's decision to place an orphan designated product outside the affordability review process is best understood as deliberate recognition that patients with rare diseases often face limited therapeutic options and heightened access vulnerabilities. For these reasons, Merck respectfully urges the board to reconsider and withdraw the selection of Keytruda for affordability review. Merck stands behind the pricing of our products. We have a long history of responsibly pricing our medicines and vaccines to reflect the benefit they provide to people and society, and the price of Keytruda reflects its value to patients and healthcare systems. The amount that any patient ultimately pays for a medicine is determined by the terms of the patient's insurance policy or by the government program in which the patient participates, for example, Medicare. Merck does not control this, but we do have national level data on these costs. For example, for patients with commercial insurance who received a 200 milligram dose, 59% of patients paid no out-of-pocket costs for Keytruda. For those patients who did have out-of-pocket costs, approximately 80% of patients paid between 1 cent and $375 per infusion after satisfying their deductible. At Merck, we have a long-standing commitment to developing and to delivering life-changing medicines and vaccines, and to prioritizing access and affordability for our patients. We believe that no one should go without the medicines or vaccines they need and are committed to helping patients access the medicines they rely on while protecting the innovation that makes future breakthroughs possible. I also had a few comments related to process. The board proposes to review products with orphan designation, but excludes consideration of patients with those designated conditions. So in doing so, the PDAB effectively is making protected patients invisible in the affordability review, but ultimately subjecting them to the outcome of the review. The proposed carve-out approach is attempting to use in the review of Keytruda prevents several structural and procedural issues. Recognizing that I am up against time, I do refer you to our written comments, and also Merck respectively urges the board to reconsider withdrawing Keytruda from the review, and we very much thank you for this opportunity to comment.
Thank you for being here today. Melissa, I see that your hand was raised, so I wanted to give you the floor.
Oh, that was for the timer, Chair Bailey.
Oh, okay. I
Yeah.
appreciate it. Thank you very much. Do any board members have any questions for Terry Lee at this time? All right. Well, with no questions, again, thank you for being here today.
Thank you so much.
Since we only had one speaker sign up to provide testimony, I did want to just make sure we're opening the floor to hear from anyone here today who would like to provide additional comments. I'd also like to mention to board members that, review the names that are of individuals that maybe you've already heard from earlier, or that you can see listed here. If you have any questions, if those individuals are interested in responding, I would certainly want to encourage anyone on the board to also ask. Joanna Wilson, I see that your hand is raised. Welcome. You have the floor and you have 5 minutes. Oh, sorry. Yeah,
And
Melissa did need to make you
I-
co-host. So welcome.
Yes, thank you, Chair Bailey. I have just made Joanna, I have made you a co-host, so you should be able to turn on your camera.
I'm making sure the interpreter can see me. Yes. I just have a question for you. There's a lot of deaf people that have been asking me this question when it comes to medications. They're afraid, like at the hospital, will charge them for medications that's more expensive than if they went to a normal pharmacy. Do you know anything about that?
I mean, I can just respond from my own personal perspective and welcome any board members' additional thoughts. I would say, so that if they're saying that they're like a hospital outpatient pharmacy, it sounds like they might be concerned. I would say if these are insured individuals, that's really more plan design and network related to how their individual insurer might have designed what the economic terms look like. So possibly there's a preferred retail network with certain regional pharmacy groups or things, but on the insured side, that would be, the answer that I would give is it's really more, that would be a question to ask your insurance company about.
Yeah. It's just a lot of deaf people aren't used to that surprise bill because I know, I've cut my medicine because it's too expensive with my insurance. So, I just was wondering if anybody had any other information on that. So I think that's all for me, but thank you so much.
Yeah, I mean, the one thing I would add though, I guess, is for people who are underinsured or uninsured too, sometimes the hospitals and federally qualified health centers and things can be a safety net provider and, provide medications, for those populations kind of under a spend down arrangement or something to try to help make some of those drugs more affordable. That's if those are federal programs that are not under our, ability to really do anything more than just provide some enhanced visibility. But I would definitely say if there's individuals in that case, that these types of safety net providers may be able to help related to drug affordability. Mr. Murray, your hand is raised. You have the floor.
Yeah, as a pharmacist who sees these challenges with patients unable to pay for their prescriptions on a weekly basis, I was dismayed to see some of the letters that came in of people that have experienced difficulties getting their medicine, and it kind of looked like a breakdown of quality of service to me. And I would say that I hope this isn't a case where this applies to the example given here. The letters that were received about not having a prior authorization mentioned is a real detriment to the patient, and it shows the holes in our consistency of care through the healthcare spectrum. And unfortunately, the advice I give to many of my patients, and we try to provide this role, is though they must advocate for themselves to the very best of their ability. And I know people have a difficult time doing that, or they get dissuaded by bureaucracy and levels of difficulty, whether it's with their healthcare provider or their pharmacy provider or their insurance company. I would just really encourage them to not give up. Go to find the help that you need. In this case, if it's contacting the insurance company, find an advocacy group that will help you. Many of them were on our meeting today. Reference them, reach out to them. They are there and want to hear from you, as do we, as do I, as a pharmacist, want to hear from you. When you come into my pharmacy, I will reach out and help. And so I'm dismayed to hear that. Your comments, Chair Bailey, about reaching out in this particular case on insurance, I think it is an issue. There are unfortunately several reasons that this could be the case, that this person is worried about the cost at one location versus another, whether it's a network or whatever it is. So there was a good suggestion in this case. but I would suggest to patients, seek help. There is help out there. The unfortunate part, just like whether it's voter participation in our recent election or it's participation in our outreach, it's low because people are intimidated. And I fear sometimes, I'll just get on my soapbox a little bit, that it's intentional. I hate to say it, but I've seen where it looks intentional, and we try to overcome that when help is, when you find the right person, right organization to help. So thank you.
Thank you, Mr. Murray. Lauren Sant, your hand was raised, so I wanted to make sure that you have an opportunity to have the floor.
And this is Joanna. I just want to say thank you so much, everyone.
You're very welcome. Lauren Sant, I know that Melissa may have to momentarily pause to make you co-host. Oh, I see that you're now co-host. So Lauren, welcome.
Thank you. Thanks for allowing me to speak again. I just want to reiterate what I have said in past meetings, that I really, really question you guys reviewing cancer drugs. Cancer is not something that we should mess with. We shouldn't mess with cancer patients. Any unintended consequences of this could be detrimental to people that may have a life-saving opportunity here. And as a 27-year advocate of people with lung cancer, options are getting more and more available, but many of them are mixed and put together with Keytruda. So I really don't want to see any changes to anything that affect the availability of any cancer drug for anyone living with cancer. It's toxic enough. They don't need any more challenges in their life. So please consider that as you go through your reviews. Thank you.
Thank you, Lauren. Vice Chair Dr. Hartung, your hand was raised, so you have the floor.
This is just a comment based on the previous comment about this affordability after being discharged from the hospital. And I think, unfortunately, in that specific situation, I think people are over a barrel if you're coming out of the hospital. But at one of the patient engagement sessions, I was made aware of that, the Oregon Department of Consumer and Business Services has a wide array of kind of consumer advocates to help patients and consumers in a variety of settings, not just prescription drug affordability, but also insurance issues and things like that. And so I think that there are resources, and I don't have all the details at the top of my head, but are resources through that division for individuals to call that division to get actual assistance from experts within the state if they feel like they're being having a disservice in a variety of different settings. So, and again, I don't have all the details there, but
No, that visibility was made apparent at the public meetings that I participated in too. So thank you for mentioning that. Maybe as a takeaway, Melissa, the information that was presented at those public meetings related to that division specifically, we could at least get to Crystal Kuster, who mentioned that, because I just want to make sure that, that we do provide as a follow-up the specific contact information, because then she could make that available.
I'm sorry, this is the interpreter. I was actually interpreting for Joanna Wilson.
Oh, sorry, yes.
So not to the interpreter, but to Joanna.
To Joanna.
Thank you.
Thank you very
Yes.
much. But yeah, we'll
Sure.
make sure we make that
I will do
available.
that, Chair Bailey. I will send that to Joanna.
And if we continue this dialogue, maybe maybe we could do a screen share or something to their website or something. I see Joanna here. Hi, Joanna.
Yes, thank you so much. I really appreciate it. I wanted you to be able to see my face and know that it wasn't the interpreter. But yes, it was me that needed the information. So thank you so much.
Thank you. Thank you. Mr. Murray, your hand is raised. You have the floor.
Yeah, I just wanted to comment of what Lauren was talking about, chemotherapy medications and difficulty in acquiring them. My son he's a nurse, is studying to be a nurse practitioner by the end of this year, and he works in an oncology clinic, and he is thinking of being a nurse practitioner in oncology. He said he works primarily to get access to these medications for these patients. he said in this year, this calendar year, this changeover, it has gotten so much more difficult to get medications approved. They're routinely denied 2 or 3 or 4 times before they're finally approved. And he said it's gotten worse and worse over the last 3 years. So I would echo what Lauren was saying.
Mr. Murray, thank you for sharing that. I think that also some of those types of KPIs, I know when we talk about the data call and things, we are trying to seek some of that information related, but I think it's a little more biopic where it's just, did it have a PA? How long did it take to get it approved? But to your point, when you're at the multiple PAs, I think that's a piece of plan design that does impact access at a minimum, right? I think the other part that we can't separate back to the question that was presented on about being able to get the medication at a hospital or at a network pharmacy. I think I just also want to personally share, that's why I think you also can't de-link some of the discussions we're having right now with PBM reform and things, right? So if there's not pharmacies, so to your point, John, you mentioned that possibly Joanna had a challenge, like maybe there was a staffing issue somewhere or something like that. Staffing issues and access are directly linked to reimbursement that providers receive and plan design, right? So I think that's just wanted to piggyback, John, on your comment, that's something that I think has to be still part of the discussion because it's directly related to affordability and access. Board members, after kind of seeing all the attendees, here today, do you have any attendees that you might want to seek questions or clarification from? I was just kind of going through the pages of attendees myself. So if we don't have any further questions from attendees here today of board members, and if we also don't have any additional questions from board members to attendees, then I will move forward then with announcing the date and time of our next board meeting, which is actually, Courtney, your hand is raised. I also see we had some people enter the waiting room, so thank you for pausing me. Courtney, you have the floor.
Yeah, Chair Bailey, there's a portion of the agenda where staff can provide additional updates. I do have some updates I needed to go over with the board members before.
Thank you. My apologies. I think I'm struggling with the meeting notes today on my end, so I appreciate that. Thank you. I see we have 30 minutes designed for that, so welcome, Courtney.
It might be a little bit longer, but I do want to wait until this session is completely done with all the attendees. So I'm going to log off until
I appreciate that. Thank you very much, Courtney. So I do see that Joanna Wilson's hand is raised. So welcome back, Joanna, and you have the floor.
So I'm wondering if I could attend the next meeting, because I'm very interested. These are very interesting to me, what I'm learning from this board member, and then what I glean from here, then I can provide to the deaf community. So so then there's less fear within the deaf community. They have more education and they're more knowledgeable. So is it appropriate to attend the next meetings?
Absolutely. We have them on the third Wednesday of every month. So I would encourage you to come. I would encourage anyone in your community that's interested to come. We also always have an opportunity for general public comment. So we always would welcome having attendees you do have to sign up for that. There's a process, but we would very much welcome that. The other thing I would just say at a personal level, because I expressed this at all the listening sessions that we did, is I'm also passionate about really helping individuals. So please feel free to reach out to me directly if someone needs some extra support navigating related to medications. It's just something I do all the time to help people. I'm at an individual level. Again, I know there's advocacy organizations here that also can help bridge that, but I don't think I ever leave a listening session without helping someone find a way to directly improve affordability in their own lives. At the Ben listening session, that resulted in about $1,200 a year that saved that individual. So it's just something I'm very personally passionate about, helping people both related to the work we're doing, but also very much at an individual level.
Okay, great. Thank you so much.
Absolutely. But Mr. Lehman, you have your hand raised and you have the floor.
Chair Bailey, while we're still in this section, and because we've had so many community-based organizations and patient advocacy groups, to Lori's earlier point, I think it is important for them to know that we still have those feedback forms out there, right? So, I mean, we didn't get maybe the attendance at all of the meetings, the engagement sessions we wanted, but if those groups could help share the QR code or get patients to fill out those feedback forms, I mean, you can see through this meeting how important your, Oregonians' opinions and feedback is to the board. That would be very impactful information to get. So any way you guys could help us in sharing those forms so we could get more feedback. And Joanna, that includes you with the deaf community. That would be very helpful to the board.
Absolutely. Like looking at the names here, we also have pharmacy representatives here. So I would lean into the same message with some of the organizations that support pharmacies, is just helping through retail pharmacies and things, also enhance the visibility of that QR code and feedback form so that we can get, as much feedback from Oregonians as possible. Is there anyone who has something they'd like to share, but's maybe been thinking about it for a while and mulling it over? And I would welcome any of those individuals to provide additional context or comment for us today.
This is Joanna again. So I was in a meeting the other day. There was an individual there and there was a form. It was a kind of an open card and looking for some understanding. So they were looking at modifying kind of like to make it more layman's language instead of so technical. So some of those open, cards or some of those open feedback forms, if you could please make sure that you keep it kind of at a layman's level, like a third grade, because deaf and hard of hearing people typically are language deprived or second language learners. Some of them have a really difficult time with English as a second language. So just wanted to make sure that some of those feedback forms that you're providing, make sure they're in like a layman's form or in a lower kind of a lower language so that people of the deaf community can understand it completely.
That's very meaningful feedback. So thank you very much.
Yeah, sure.
Yeah, we'll work on that. And obviously I would say, we're very open to just feedback on it. I mean, or suggestions on the edits for staff to review. But thank you for sharing that.
You're welcome.
Okay, well, I guess I will this time try to do it accurately and not skip over our PDAB staff general discussion. So I would like to welcome the conversation from PDAB staff related to general discussions for the board.
Thank you, Chair Bailey and board. Before I dive in, we're probably going to need a lot more than a half hour. No, I don't know why that was put in there, but can we maybe take a break for about 5 minutes since we've kind of been at this for a couple hours and kind of reset ourselves before we start into the next agenda?
Courtney, I think that's a very good suggestion. So we will go ahead and break for 5 minutes. All right, welcome back, Melissa. If we could just do a quick roll check before moving forward with our discussion with staff, that would just help me be aware that we have everyone here today.
Yes, Chair Bailey.
Thank you.
I will do a roll call. Chair Shelley Bailey.
Present.
Vice Chair Dan Hartung.
Present.
Lori Hoagland. We'll come back to Lori. Dan Kennedy.
Present.
Michelle Coder.
Present.
Chris Lehman.
Present.
John Murray.
Present.
We have quorum.
Perfect. Thank you, Melissa. So, Courtney, we are now moving to the general discussion by staff period of our meeting. So welcome back, and you have the floor.
Thank you, Chair Bailey, and good morning, staff. I was going to share my screen to share this time frame, but Melissa beat me to the punch. I wanted to spend a little bit of time, since we have some time in the meeting, to go over a couple of kind of information the staff is seeking from board members. But before I jump into that component of our upcoming review, what's the PDAB meeting, without showing the kind of roadmap on where we're at and where we're going. So I think this meeting has been very successful in capturing patient feedback and kind of meaningful input from the community. And I also want to give a big thank you to Lou and Sarah and Melissa for all their due diligence to reaching out to get these forms put together for in-person, even though we may not have had a significant turnout to the in-person and online forums. I do believe that the engagement has been meaningful as we start setting up to incorporate more patient feedback perspective, especially around not just affordability, but also access. So thank you to Sarah for spending more time this last few weeks, and Melissa for all your due diligence in getting this all organized. Because a big portion of the feedback from these forums will be hopefully incorporated in some capacity into this review cycle. And again, when the intention is not just to look at the cost, but the overall kind of what's happening with this drug from a patient's perspective, from the health perspective. So I think that, for May, we have done a very successful job in getting one component of the material information to the board, and having this forum to continue for the board to come together to ask these questions and have the dialogue. So starting next month, we will start jumping into the material packet reviews. We're starting with group 1, which is our GLP-1s and the insulin products. So if you recall, we selected Humulin RU500, both the concentrate and the quick pen. We have Jardiance, Ozempic, and Mounjaro. The anti-diabetics were previously reviewed in the last cycle, with Trulicity being determined as a drug that may potentially have an impact on patient out-of-pocket cost and the system. So the intention for the GLP-1s is kind of seeing what a year-over-year benchmarking is, what the kind of concept is. So it's kind of good that we're starting with these packets. It's also helping us to set up the packet material in general for the upcoming additional reviews. So the intention is for June, July, and August to kind of have a broad discussion about the drugs, the material, and the information within the material. They're going to be what we're calling rolling packets, which means that changes may be applied to these packets. There'll be versions of these packets that will be posted as information it comes in, so that when we get to September and October, we're going to make them solid packets or final packets, where then the board can take those 2 months and really start diving into meaningful discussion about the affordability impact. And on top of that, starting in July, it's already kind of been mentioned today, but really start diving into policy recommendation discussions. And my ask for the board is, if you start having policy recommendation ideas, please let me know as soon as possible. My intention for this year's policy recommendation is to provide policy memos, like what I did with the price caps and the rebate pass-through. Probably won't be as extensive information. I'm hoping to do kind of a shorter version, and then any recommendations that are voted on or considered to be high interest, I would expand those policy memos with additional research to them. Chair Bailey, I see your hand up.
Thank you, Courtney. I was just seeking a little clarification on that. My understanding was that we did have the policy recommendation discussion earlier in the year, and the board on the meeting I was absent on, but the board did vote, I thought, on the concepts they wanted to potentially discuss adding in the annual report. Am I hearing you right that that discussion, that board members could still provide something different than what they voted to advance a couple of meetings ago? I just want clarity for the board members and the public on that.
Yeah, so back in January, February,
It
the
was
concepts were
February
rolled out.
because I had surgery in
Okay.
February, so I remember
Yeah,
that. It was a February meeting.
But for in January and February, the recommendations were set up into two different buckets. One was pretty much directed around the drugs under review, and another was the high concept. I'm happy to pull those drugs back, or those recommendations back out for mini policy recommendations, but the board did not vote on any of those to be advanced. It was decided at that time that the recommendations were not what the board wanted to see to go forward for that review cycle report.
Yeah, so I guess what I'm trying to clarify is just I'm familiar with the two that you know we were continuing to discuss, but are you saying that the board can provide either lean in more to those two and fine tune it, or is it that the board can still provide something new? I just want to make sure that all board members understand and the public understands. But Sarah, I also see your hand is raised. So
before I just want to have an opportunity to clarify what I mean. The price cap memo that was submitted into the drug report for the review and the rebate pass-through have already gone to the legislators. That does not need to come forward again for policy recommendations. There were prior recommendations that were not voted in for the report that we can bring back forward for the board members to reconsider to put into for this year's.
Okay, that's the part. Okay, and then board members could, of course, provide new concepts if they wanted or something. Thank you for clarifying that.
Yeah, and just to build on what Courtney was saying, you know, one thing, again, trying to improve our processes that we are trying to work on is how we can better support the board members to make sure that you have time both to identify those policy ideas, but then that we also have time to do that background research and development to really put them forward, give them their best foot forward, because that was one of the challenges we ran into in the context of the 2025 drug review report, which of course we actually published in March of this year. We didn't have time to fully expand and refine some of those ideas. So we want to start that conversation now at the front end of the drug review to make sure we're getting direction from the board on which potential policy concepts you want us to research and you know, where you want to explore so that we have that ready to go for this year's annual report to the legislature.
All right, thanks, Sarah. I appreciate that clarification. And I guess while we're still on the topic, are there any other board members that have questions regarding kind of the recommendation component? And again, I will be reaching out with more clarifying kind of questions and feedback to the board to provide or to shore up what the board has already been discussing from the beginning of the year. Yes, John, I see your hands up.
No, I just want to say I appreciate this opportunity. Thank you, because I've been advocating it for some time, and I will put forward some ideas maybe for board consideration. So thank you.
Yes, thanks. And I appreciate always working with board members and how to provide these recommendations to be as meaningful as possible in our reports. So yes, so starting July, we will also be incorporating policy discussions into the discussions with the material packets. I know we've kind of already touched base that the data call information is in. We are still in the process of trying to get the last bit of it shored up to start incorporating the data into the material packets. But the first round or the first group will be done for next month's discussion. And then I'm also going to lean into kind of some updates I have for the material packet, but I'm going to jump into that in just a moment. And then again, for the public, really looking forward to getting more feedback on the forums. Last year, the board really leaned into the public or the comment components of those. So I think some of the feedback is meaningful. And then this year, we really shored up to have more structured kind of selections. And I know that might not always be ideal to have close-ended questions, but for the need of what we were kind of looking at to capture for the impact of the drug under review, those questions we felt are as meaningful for the board to understand what's happening for patient access and affordability. So again, high level of our kind of roadmap of where we're at. Before I transition, I really want to make sure that the board understands starting next month, we start with our GLP-1s, followed by our other two groups. I'm sorry, I don't have those ones completely memorized off the top of my head yet. But then September and October, drug packets will be finalized. And that's where the board will really start their discussion and how to determine how you want to determine your review or your acceptance this year. It's really important that we have a vote no later than the first part of November. Preferably October would be better, so we have that time to write the report to be very meaningful, because it does take us a long time to write the report. And then with that final vote in December, it would be the goal to finish the report or vote on the report in December and actually start taking a sneak peek at what the 2027 drug list would look like. So I know it's a lot of information in a small amount of time, especially with the amount of work that we have to do, but it's really important that everybody always has this on your radar, that it's really important to review the information and come prepared to the meetings for these meaningful discussions. And if there's anything during the reviews prior to the board discussions that you see that's in the material packet, please reach out to staff so that we can correct them prior to the meeting time. So, yes, Dan, where I jump into my next portion.
I'm just wondering, so looking at this time frame here, we have the packet reviews kind of mapped out, and then November 18th, vote for final report. And just thinking back at the last cycle, it seemed pretty it's a kind of a cognitive load to go back through all those reports again and kind of think about them again at the when we finally voted on what ones we were going to advance to the legislature. And I'm wondering if it makes any sense, given that we're not supposed to make some comparative assessments between these candidate subset drugs, if it makes sense to vote on the drugs within the meetings that they're reviewed, so both they're we're doing a deep analysis of the reports and it's fresh in our minds.
I would say that might be a discussion for the board to have and how you want to set it up. Again, the intention was to have kind of meaningful discussion for each group of drugs, June, July, and August. But if you want those drugs set up into specific groups for September and October for votes being each of those months, the board needs to have that discussion and lead staff in what your preference would be. Chris, I see your hand up.
Yeah, I don't know about voting for inclusion in the report, but I could see us, reviewing 3 or 4 drugs and saying, hey, this one doesn't seem like it's going to be a candidate for inclusion in the report, and us sort of voting to say we're okay excluding this one, so that when we get to November, instead of having all of them together, maybe we're able to filter 3 to 5 of them out before we get to that point, so we can have a more thorough discussion at the November meeting, if that's something the board would be interested in. But I think it's going to be hard for us to say before we've looked at everything, yes, this one is in.
Yeah, no, that's a great point. And we can always, I think, revisit these things at the end, but just I think doing some sort of deliberative taking some sort of deliberative action if you either just exclude them or flag them for further focus would be helpful.
I do want to remind us that when we started the 2023 reviews that we paused, we were initially structured that way and we were ultimately voting in each meeting. And I think as I had to go back to the exact meeting notes to look, but I believe as a board, we felt that was a little bit problematic and we identified that when we were doing it. Again, we had a different language related to nine drugs and one insulin, where now we have up to. So that does give us some flexibility. The other thing I would want to mention though, I also want to be mindful of the sufficient time for public comment, that we are definitely keeping in mind the public comment opportunity piece without somehow lessening the window, because for some of these drugs then there would be less public comment time. So I don't disagree, Vice Chair Hartung, related to the cognitive load at the last meeting. I just want to be kind of mindful of those few things.
That's a
Do
good
other
that's a good point. Sorry. The public comment piece especially.
Well,
And I
and
guess
to follow
okay,
that, yeah, to follow that, the public comment components would only be within up until August. Really, because then in September and October, it's been found that the board does a lot more constructive discussion when you have a couple months to kind of break up what those groups would be and how you want to review them. But I appreciate the conversation, and I do think that the process of how the board wants to either parse them out and vote the drugs in September, October, either vote them out or, put them on a list to vote them in. Because during the first cycle, it was a vote to put them on a list for consideration towards the end of the cycle. It wasn't that they were voted in as being determined unaffordable or impact the healthcare system or patient out-of-pocket costs. The intention was just to put forth the drug to for the final review. So kind of like what Dan was saying, if during the discussions in June, July, August, and the board's like, well, we're really not seeing any impact, we don't need to continue to have a discussion in September and October for this, you as a board do not have to continue to review those drugs. Or you can put it as a vote that you don't want to or you do want to. So we've done it a couple different ways. And again, this is kind of one of those discussion points that I think is meaningful to have right now, so that not only staff knows, but the board knows the direction of how you want to functionally determine the this year's or this review cycle. The other option is, I would say, take this and think about it, and then at the beginning of next month's board meeting, we structure that decision. But happy to keep the conversation and what the board would like to do or feels best.
I think that's a fair comment, Courtney, to have board reflect. I guess I would say my other thought, I mean, this time we do have less drugs that, that we have been looking at, but I wouldn't want to somehow, if we're excluding some before the 2-month full review, like somehow make it seem or end up in the kind of outcome where either more or more drugs may end. I mean, essentially then we're creating a draft list or something. And I guess I would want to be mindful of process and just making sure that we're not biasing ourselves in any way that would make the outcome of how we each individually vote different. I guess I don't know. I don't know if I'm just rambling, but I'm just really trying to to think about that, but I think you're right, Courtney. We should, for all board members' sake and for the public's sake, I do think for the next board meeting, we should decide as a board. So we have that answer done. So thank you, Vice Chair Dr. Hartung, for bringing that up.
We will capture that to put as an agenda topic for next month in order to
Thank
get
you.
the review set up.
Thank you very much.
Yes. So before moving on, any other questions, feedback from board members? All right. Seeing none, I'm going to ask Melissa to stop sharing screen. And I'm going to ask the board, I sent out an email, or an email was sent to the board requesting information or any constructive feedback regarding the material packets. And we did receive some feedback from board member, and it was constructive, and I really appreciate that. I just wanted to kind of run through the highlights of the updated material packet so that the board's kind of aware of what's going to be happening. I also did pull the rubric. So if we have time, I'd like to just kind of go over how some of the rubrics may be updated. But again, until I get the actual data into these material packets, I don't know for sure how some of the rubric scoring or yes/no answers will be altered. But again, that will all be provided to you as an update at next month's meeting. But I just wanted to share at this opportunity where we're at with the material packets. And apologies as I get my screen set up. Still keeping the same outline with indication of the proprietary, non-proprietary name, version control, and the image. We'll have a version control history page again. There's a review summary. Really, we're not changing much. I'm just highlighting any drug that's on the MFP and the year that it was listed. Price history will be marked out again, just kind of providing the overview between the WAC and the AAAC information, along with highlights of any price concessions, cost from payers, and employee cost to the enrollees. So I know this is all kind of familiar. I did want to.
I see that Michelle has her hand, so I just wanted to.
Yeah, I was kidding. Yes, Michelle, I see your hands up.
Thank you. Courtney, I have a question on, it just dawned on me, the, oh, I see the patent date range. Okay, so you'll put the earliest to expire and the furthest?
Mm-hmm.
Okay.
Yeah. Is that what? Okay. Just making sure we're capturing material. Yeah. So again, this is just super high. The level, some of this information is a lot more detailed in the packet, but we can make sure that we're capturing, patent date, number of patents, and then the exclusivity expiration. Was there anything else in the summary section that the board found relevant or irrelevant, needed updated? So seeing none, we're just going to probably then keep this structure kind of the same. Also, under the last review, we did include information about the rubric consideration. This will probably be updated a little bit more. One of the things that has already been updated is that the rubric indicated utilization, which is more aligned with claims information. And so we're just clarifying that the domain is the number of enrollees and not the number of claims. So just specifying that a little more clearly between the rubric and this portion of the material packet. So review background will be updated with how current structure similar stuff as what the board does, how we got to where we're at, and what this review cycle is about. Drug information is basically just a snapshot of the drug based on the manufacturer, the treatment, dosage, quick snapshot. I did want to ask the board something. So since we are leaning a lot more into also understanding the therapeutic alternatives to these drugs, does the board want to see snapshots of label information in this, or would it be helpful to see it in an appendix for each therapeutic alternative? It is one thing for us to go and put in for the subject drug. It's a little more work to do for the therapeutic alternatives. And a suggestion was probably to include the information around the therapeutic alternatives to see if that would be meaningful for the cost review. The only thing I'd say is because these can be kind of lengthy and take up quite a bit of space in the report, is then actually add them into an appendix at the end. So if it's a choice to go look at what the manufacturer information would be, you just go down to the appendix. So that would be one of the changes I wanted to see what the board's suggestion would be on. John, yeah, I see your hands up.
Would it be possible, I don't know the level of work this would require, but there's been discussion about therapeutic alternatives and whether they match up on indications or not. Could an appendix be listed for the drugs on the report, but also the therapeutic alternatives with the indications that they're approved for? Would that be too much of a bite or not?
Since these are rolling route packets, I think we can probably do it. Just know that the first go around packet might be a little shy with that information, since we have to get all the data into the material packets first. But I'm sure we could kind of find a way to massage it in there before the final packets are delivered. Yes, Sarah.
And following up on your comment, John, I think that's an area where it would be really helpful for staff if you as board members have feedback on the initial draft of this document. How do you want that information organized? Is there additional information you want to see? You know, providing us that feedback early, soon as we get this first batch of drug review reports delivered to the board, start thinking about those things will be really helpful feedback so that staff can provide what you're looking for.
Yeah. I can just kind of note if I can put it in here initially, if I can find it easily. If it's gonna take time to shore up, then I might have to lean into board members to help clarify it a little bit. But Mr. Kennedy, I see your hand up.
Yes, I was just going to say, Courtney, that I'm perfectly okay with that information in an appendix form. I think that makes sense. Just sort of condensing the report and referring to information in the appendix.
Perfect. Thank you. Yes, Chris.
I agree with Dan totally. And then Dr. Hartung, I had a question for you. I mean, just instead of having pages and pages in an appendix, is there a way that, like a table or something, that you could envision where they're sort of compared instead of just having to read, pages about the therapeutic alternatives and their indications, et cetera? I don't know if there's a better way to display that so it would be something easier to just understand without having to read through everything.
Yeah. I mean, I think I've seen iterations of something similar in prior reports where, I guess first of all, I agree with the sentiment that moving some of this stuff to the appendix makes sense. I think the board, we realized that these drugs they're not perfect alternatives, and there's going to be some non-concordance in indications and effectiveness and safety and things like that. And so, I think some sort of table that's got all the drugs that are considered therapeutic alternatives by whatever, approach we have with maybe like if there's mix and match of indications and like maybe like check boxes or whatever that they, which ones have all the different indications and which ones only have a few, like the GLP-1, some of our diabetes, obesity, all the other comorbid conditions around both of those conditions. I could see some sort of like graphical display. Again, these are all like, potentially more high lift type things for staff. And I guess in the main document, I think some of this we've already had, like, just comparative cost information, I think should be front and center, utilization, stuff like that.
Yeah, it's the focus. Chair Bailey, see your hands up.
Yeah, thank you for asking the board this question. I mean, I'm always cautious with the comparative. I mean, I liked Mr. Lehman's comment maybe about the checklist, again, if it's or the check of indications and approved uses. But I mean, I also recognize this could be an enormous administrative lift for staff. But I'm always very cautious of when we're doing. So personally, last year, like I leaned a lot into the dashboard to do looking at therapeutic alternatives from the cost perspective. Like I used the dashboard a lot, but at least I felt last year, the information we provided, at least for me, on therapeutic alternative manufacturer info was sufficient, or wasn't from the, I mean, I felt I had enough, because I do worry about approved uses and then putting all of these, like, I feel it could lead to more challenging and possibly inaccurate decision making. I don't know. That was just my personal thoughts on it. So I'm just mindful, because I just want to, it's just something that causes me to pause.
Yeah, and of course we'll work within, staff will work within the capacity that we have right now. The other thing is that we have the clinical information section, and there's quite a bit of clinical comparison of the drugs in that section. So, that might also help capture where some of these condition overlies are. So, but we'll see if we can maybe create like a quicker snapshot at under like this section or in the appendix. So I'll have to think about it, or reach out to staff or board members to kind of see what else we can do considering time frame and the lift. But I think it is important that if it's something that's meaningful for the board to know, we can start looking at how to incorporate that in some capacity. So thank you for that. The health equities section is being updated. I have been able to gain data out of APAC with a lot of caveats, meaning that there's a lot of unknown and a lot of information that's a little more challenging. So, but I do need to know what the board kind of wants to lean into. This is junk data, so please just know that I just pulled this up to see what the board wanted to do. I do have access. I was able to pull it this morning and create meaningfulness. I just didn't have the time to put it as junk data into this form, but I do have co-payment, co-insurance, and deductible and payer paid amount. So looking at kind of pivot table concepts, we can look at line of business on the claims, enrollees, and the percent enrollees impacted, urban flags, race, ethnicity, and gender. Again, looking at the number of claims per enrollee versus the percentage. That is, a way to kind of get some of this, equity data into the report and then create a summary. My question for the board is, there's a lot of data points here, and I really need guidance for what is the most meaningful. Is it really around the race? Is there like a way to combine, like line of business versus urban flag for cost? So I know I'm kind of throwing this at you only because I just did it this morning really early. But are you more interested in understanding claims and enrolling numbers, or should I also lean into, again, anything that has like the co-pay, co-insurance, payer paid, and then what those might also look like? So I want to have this discussion. What does the board want to see when it comes to looking at health equity information? Chair Bailey, I see your hand up. Oh, and you're on mute.
Thank you. One initial thought I have, and I was just trying to think right now of where you could pull this. One thing that would be meaningful to me for individuals, like the rural part is what got my head, is how far away, or like how many pharmacies are even in the county of these individuals, and map that against like the number of enrollees, because I think what we'll find is a lot of pharmacy deserts, and I think accessibility is a big piece of this equity discussion. And so I'm trying to think of like where we could get just the data of mapping what currently open pharmacies against patient zip code or something. I don't know if that's way too out there. I mean, this is your data that's built, that is, available to you, but I think that part is an important part. I don't know how other board members feel, but I did want to make, okay, if you want to finish the answer, and then I'll make sure to recognize Sarah.
Yeah, thanks. So one of the things is we don't have the, or I didn't have pulled the pharmacy zip code information because it actually creates too much of a narrow acuity.
Oh yeah. Okay.
So we have to kind of be mindful. I'm happy to continue. This is, again, the first time we're seeing this. Next year, we might be able to get a lot more granular. So what I'm presenting to you is something that we can do right now that's easy and accessible for the staff to do. And like I said, I don't have it shown right here, but also understand that I can work with copay, co-insurance, deductible, and either put those out as actual sums or the percent differences, either through the line of business, urban flag, and race. I know looking at the details would be very meaningful. Unfortunately, for this stuff right now, it will be an improvement for next review cycle kind of thing. So, but for the first time having it what we do, I would really like to see what the board would like to kind of lean into. But I see Dr. Hartung, unless Sarah, do you have something on this that you wanted to add in before addressing Dr. Hartung?
I think it would be helpful. And could you zoom that in a couple more clicks, actually, Courtney? So one thing I want to draw all the board members' attention to, just so you understand the limitations of the data that we have available, is especially on race and ethnicity. We have a lot of individuals with missing data. So in some cases, missing or unknown may be our biggest category. That's just a reality of the way data are reported in APAC. And so that's what we have. Another thing, we do not know the counties where patients are located or the patient zip codes. That is protected information the way APAC is structured. We do have information about the zip codes of pharmacies where people are filling their claims, but we don't have information about the patient's zip code. Technically, we have it at the 3-digit zip code level, but those are multi-county areas, so they're somewhat difficult to analyze. So the categories that Courtney is showing are the things that the staff have been able to identify in APAC as currently available.
Yeah, that's
and
what she shared.
The urban flag is where the contractor puts an indicator on that patient's file if that patient lives in a place defined as rural or a place defined as urban by OHA and the Oregon Office of Rural Health. But of course, we don't know which part of rural Oregon or which part of urban Oregon that patient is in. So I hope that clarifies some of the limitations of the data.
Thank you for sharing.
Dr. Hartung, here.
Yeah, this is great. I understand the limitations of the data. I think, and I understand the your capacity limitations in terms of your work ahead of you. I think if you in my opinion, focusing on just the breakdown of enrollees, proportion of enrollees who, in terms of race, ethnicity, gender, and if this urban flag reflects what our vendor has assigned to them, just, you know, breaking that down, given the caveats associated with that, I think that would be a tremendous advance from the previous cycles. I completely agree with, you know, knowing it would be helpful to know information about pharmacy access and things like that, but you know, I also understand that's a huge analytic lift to do things like that personally. So I think, you know, just focusing on the enrollees and their demographics of the focus drugs, and if possible, alternatives, that would be a huge insight into advance over what we've previously used. The other thing, I was wondering in terms of, you know, contrasts and like context, if it's possible to have like just some boilerplate around just general Oregon demographics, just so we can kind of put this in a little bit better context. And that's just mine. Those are my comments.
Do you mean like income by county, average income by county type stuff, or what Oregon, what guidance
No,
could we give on Oregon's?
and I know we can go online and have AI spin something out, but like just like what proportion of Oregonians are in these urban rural areas, race, ethnic backgrounds of Oregonians, gender, obviously gender probably 50-50 or whatever the national average is, but just things like that, so we can have I can board members can understand inequities in relative to just the general population or comparison.
I will work on that to the best of my ability, and then also work on a strong, meaningful write-up for this section. As you can see, it's blank. So, but I appreciate the conversation. But before we move on, I want to make sure I catch Lori's. Hey there, Lori. I can only see the top of your head. I don't know if you can.
Oh, sorry. Okay.
Yeah.
Yeah. So Dr. Hartung brought up a lot of what I was also feeling, that the context of the race is not all that helpful if we don't have a means of comparing, like, you know, what percentage of the Oregon population is Asian, so that we're seeing, you know, obviously there's going to be a lower percentage of claims if there's 10% of the population versus 50% of the population. It kind of gives context a little bit more, since there are limitations with this data. So that I do think that that's very important in this context.
Yes, thank you. And again, we'll work on that as best of our, because that would mean we'd have to go back to the census information, you know, and I think the last census was out in 2020. So, you know, ensuring that whatever we're comparing that against is as accurate and up to date as possible. So, yes, Shelley, I wanted to take a moment to.
Thank you. I mean, you framed it accurately with the word I just could not think of, which was census information. So I personally, and maybe we can't do this year, but for next year, I do think, you know, average income, at least on I guess the pharmacy, we have data on the pharmacy county or something, just because I mean, obviously income disparities in different geographic areas, if out of pocket isn't also different, I mean, that's from my perspective, and affordability, like it would be a data point that shows us where there are parts of the state possibly that have more affordability challenges than others.
Dr. Hartung, your hand back up.
Yeah, one thought related to Board Member Hoagland's comment in my previous comment about the context. Perhaps even just using the APAC data themselves, like the overall pharmacy utilization world, to develop the context, like of all pharmacy users in the APAC. Here's their race ethnicity breakdown, here's their gender breakdown, here's their urban rural breakdown. I think that at least we have like some apples to apples comparisons, given the fact that half of these we have bad data or we have unknown data on race ethnicity for a large section.
Mr. Kennedy?
Yes, I would like to echo Dr. Hartung's recommendations. It seems to me that we could almost offer some sort of disclaimer saying that this is the data that we have available. So that people looking at it wouldn't just say, oh, look at unknown as the largest category here. So I think maybe disclaiming the fact that there are missing elements to this data, but we're doing our best to address health equities.
Yeah, that's of course one of the strong intentions of footnotes. Yeah, making sure that we're understanding that there are data limitations, and we're still trying to get it as meaningful as possible, but working within the parameters of limits of the data that's provided to us. Thank you. And I'm really looking forward to getting this section of the material packet past just peer review. What's been happening kind of generally, and actually incorporating it into Oregon enrollees. So this is one of the things I've been wanting to do for a couple of reviews now. So moving on to the residents prescribed. Previously, it was just showing the number of Oregonians that filled the prescription. It was also suggested to include the claims by the payers. So in this section, so you have, even though it's kind of like indicated throughout the rest of the document, just as the for this section, ensuring that the field prescription is known, and so is the number of Oregonians that filled the prescription. Yes, Michelle.
I think it might also be helpful to have the number of prescriptions per enrollee, filled per enrollee. Because if people initiate treatment but can't continue treatment due to affordability, I think that would be an important data point.
Thank you. All right. Seeing no other, yes, Dan.
I'm sorry to be
Okay.
dead. I agree. I also think you see this a lot in the cost data because the data are so skewed. You have many small number of people using a large number of drugs, and so the average is oftentimes misleading of kind of what the most common Oregonian is seeing. Like, so having that being said, having the average and the median.
All right. And is that something that you'd want to see here, or just in the tables themselves?
I think throughout it makes sense. I mean, I really struggle to like understand the distribution of these things, like, because there's just a small number of people who are utilizing a huge amount of drugs and having huge costs based on like what I look at when I see the median medians and the interquartile ranges and all that stuff. So any time we're presenting central measures of central tendency, I think having at least the medians in addition to the means, the averages, is helpful for me.
Understood. All right. So regarding the price for the drug, again, looking at price history, WAC information, where it's filled out. for the year, and then this is the average annual percent change. And so it's like something like this, Dr. Hartung, you'd want the average and the median? No.
No, I'm sorry. No, that's fine. Because that's
This
just
one's
a
good.
year-over-year change. Yeah, no, that's
Yeah.
perfect.
All right. Just making sure. Getting all the same kind of setup with graphic information, looking again at the AAAC information. I think we spent quite a bit of time on this in the last review, so it shored up pretty well. Some of these drugs have MFP pricing. I have included a snippet of what the MFP pricing would be if the drug is under MFP. So I started a narrative to capture that for the drug for this review, just as kind of like a benchmark or a kind of price comparison. Trying to get a little more data points of cost that's happening for that drug. The monetary price concessions, so again, any rebates, discounts. This is again based from the data call information on the net pricing. And so again, capturing what the percent of discount is, making that relatively known, any discounts from manufacturers, PBM or other. So hearing no feedback. Again, spend versus gross and net, and then the price per claim. This is based off of an average. Does that work for you, Dr. Hartung, the average, or do you want the median added into that?
It's more for the APAC and like the
Okay.
claim counts and cost averages. I think I'm more comfortable with this.
Okay.
But thank you for asking.
So for this of the price concession, this section will probably be harder to fill because this is the price concessions provided by manufacturers to each PBM. And so it's just a data point we do not have. And so unfortunately, it's just a gap in the review due to a lot of it is considered proprietary or trade secret information, so a little bit challenging to get that. For the estimated price for the therapeutic alternatives, this year the board will also be reviewing net pricing instead of just APAC gross. So need to work a little bit on updating this section for net inclusion, but for the therapeutic alternatives, we'll kind of revamp this table so that it's shown what the net versus gross is for this section. This is the pretty much similar to the section above for the drug under review. This is the price concession for therapeutic alternatives. So the table is going to be very much similar. Again, looking at the percent of discount of the drugs, how many therapeutic alternatives there are. I will admit, I tried to put it kind of together up above and just like referenced, it made it very messy. So I know it might be a little more challenging to see the price comparisons between two sections of the material packet, but it's a lot cleaner. I'm happy to try and put everything into one table or one frame, but it's messy. I already tried to do a test on it, and I didn't like the way it looked, but that's my opinion on it. And I'm happy to give you a squished data set if that's what the board would prefer, just having an indication that basically they have to, these two will be combined. So the other thing is we can get this data in, get the material packet developed, and then have a discussion to see what the board thinks of it. But for right now, it is a very messy data set when all of this is squished into one, especially if it has multiple therapeutic alternatives. I mean, the table gets really big and tiny. So again, looking at what the therapeutic alternative is, gross versus net, and price concession claim across lines of businesses. So that is a new section from last review. Any questions on that before I keep scrolling through? Dr. Hartung?
I have a question about the price concessions data, and I know we have, like, there's two elements that I focus on. One is the number of claims with a discount, and then what the actual discount is. And and sometimes, like, in many cases, you know, it's a high proportion of claims that have discounts. In some cases, it's pretty low, like 50%, but then the discount's like, I don't know, some other number. And so when we're figuring out the average discount, is it the average among claims that have a discount, or is it the average among all the claims if they have zero discount or a discount?
That
Oh,
would be
Heather read
across,
my mind. Thank you, Heather.
Dan, that would be across all claims is the way we currently have it calculated.
Okay.
Perfect. Thanks, Heather, for jumping on and answering that, because I was going to call her forward. That's her specialty. All right. Any other discussion on this? Nope. Okay. So health insurance plan spending, again, focusing both on APAC, so gross, and net. Again, green being APAC, blue usually representing data call. We may have to be adjusting the colors a little bit to meet accessibility review requirements. So just as a fair warn that as we put the material packets up, some of these color schemes may change, but the intention is to represent green for APAC and blue for carrier, and then orange is other. Again, looking at claims and costs. Then across line of business with IQR 75th and 95th percentile. Looking at net costs, not seeing any feedback, so I just want to make sure. So this is all based off of average plan information. Before we jump into what each impact or market line of business or market group represents. Okay, no additional feedback. All right, so I do have a question about the CCO impact based off of the DER claims from the Oregon State University. They provide a snapshot of aggregated information. It was commented last review that some of the Medicaid information really isn't as meaningful in this component because it's captured in APAC and it's very, very close to what it is. So I wanted to ask the board if you wanted me to keep this Medicaid CCO section based off of the Oregon State Durham claims. Happy to pull that and put that in. It's not consistent across all drugs. So only certain drugs are reported in their top, I think they do top 15 drugs for their payouts. But I don't know, there was never a decision point or discussion in the last review about this. So I wanted to make sure that the information included is as meaningful as possible. Yes, Dr. Hartung.
I find it less useful, just because it's again, redundant with some of the other Medicaid reporting in APAC. And I mean, I do think, I mean, the year-to-year changes are kind of helpful, but if we had that through APAC for all payer groups, that would be what we should kind of go to in terms of like future reports.
Sounds good. Any other feedback from the board?
I
All right,
personally,
so
I
yeah,
personally
go.
like this snapshot. I wouldn't disagree that information's not there in another way, but if it's not a big lift for staff, just I guess the way, I look at information, to me, that's helpful. But presented this way, I guess, is what I'm saying.
Okay. I can keep it for this. I think this is one of 3 drugs when I looked at the DUR report. Just knowing that the spend is not via rebates or anything like that. So we can put it in to see. Yeah, we can put it in, see if it's anything. But again, just trying making it as meaningful as possible. Michelle, I see your hand.
Thanks, Chair Barely. I don't think that is meaningful data without seeing the utilization. So, the year-over-year spending could increase due to increased drug costs or increased utilization.
Yeah. I can see if it shows that, and add it in if it does. Laura, I see your hand up.
Isn't this the best information we have about drug benefit design, and with, it's hard to get that information in other places.
Yeah, I mean, this is all we have for like CCO stuff that's publicly posted. And it really is just a spreadsheet we have to go into and look at. So this is kind of what we have. And it doesn't show like how their CCO plans set up on their formulary or anything like that. So, but Chair Bailey, want to?
Yeah, no, I just wanted to lean into Michelle's comment about utilization. I agree. If we can't add utilization, I would completely remove it, because I think that it doesn't represent accurately like the picture without the utilization. And I guess I maybe want to just also redact my other comment with it not including rebates. I mean, there's a lot of shifts in the market where something could be really highly utilized, it's on formulary, and it's highly rebated, but that would not be, that picture of that story would not be reflected right here. So I think I'd like to change my opinion and say I'd scrap it.
Yeah, Sarah.
So I think when we're talking about the Medicaid population, there may be two separate things here. One is the cost and utilization data that's reported in the drug use reports. As Courtney noted, those don't break out every drug, so we aren't able to individually identify all of the drugs that PDAB is reviewing in that report. Of course, the other chunk of information for Medicaid that we can provide, if useful, is what the drug's placement is on the Medicaid fee-for-service preferred drug list. If you're trying to get at the question of plan design for Medicaid patients, that preferred drug list is very informative for fee-for-service patients. Of course, each CCO serving Medicaid patients may have somewhat different drug lists for their Medicaid patient population, and just given, you know, complexities of that, I don't think it's feasible for us to get the drug coverage information from the individual CCOs, but we could pull in the statewide fee for service preferred drug list placement if that's what you're looking for, Lori.
You're on mute, Lori, so wasn't sure if you were saying something.
It's okay.
All right, well, thank you for that feedback. I'm not seeing any other hands up, so gonna scroll on through. So impact on the enrollees, access to the drug. This seemed to be one of the more meaningful discussion points for the board's decision in the last review. I did want to ask the board, would it be meaningful to know the number or percentage of carriers that had these strict requirements? Is it like 100%? I think we kind of indicate it like up here, but would it be more meaningful to see it like in the table itself? Or is there no preference? And Sarah, I saw your hand up first, and then Shelley, and then Dan.
Go for Shelley and Dan first.
Thanks. I like having it here because I think it's a very important part when we're thinking about these drug reviews. So I like having it visible like this.
Okay. Dr. Hartung.
I think I'd like to have some sort of the number of carriers that make up these percentages.
All right, we can look to do that. Sarah, back to you.
I guess following up on Dr. Hartung's comment, I also wanted to ask the board, one of the data complexities that I've been thinking about with our data from the commercial carriers is there's a wide variation in how many members different carriers are serving, from a few thousand to over 100,000. So I don't, do you want us to explore some kind of way to scale this by number of members? Because, you know, in our data, we have 2 plans, but one of the plans may have 10 times more members than another.
Yeah, Dan, can I see your hand up and then?
Yeah, I see this as pretty much reflective of plan design and formulary design. So I would just like to say I enjoy seeing it here too. Regardless of the number of people in the plan, it still really just shows the steps that the plan has put in place to restrict access.
All right, Dr. Hartung.
That's a great point, Director Young brings up about the size of the plans. I mean, a simple thing you could do is just, you know, break it down into, or again, simple, but it's also additional piece of work to do, but have like large plans, small plans, or whatever. Anyway, some that would be, you know, meaningful breakdown by the ones that have the most people, the smallest number of individuals. More sophisticated approaches would be like weighted, like where plans that have the highest number of enrollees are weighted larger, but that's a little bit more involved. So just having subgroup it out by plan size in a simple way might achieve that end.
We'll work on something like that. Chair Bailey.
I like Vice Chair Dr. Hartung's comment related to narrow kind of identifying it that way. Provocative question. I'm assuming we're prohibited from listing it per plan. Is that confidential information? But if we have which plans, because, obviously some plans, I mean, it's very different across plans, like, is that considered confidential information or can we put that in? Because to me, that would be an important data point. Because that also goes back to equity and what plans are in different geographic markets and like, is that something we are able to do?
My understanding is that as long as it is aggregated and not and really specific information, because like the drug price transparency programs, they list out quite a bit for each individual plan and certain information, but really I think it would be a call for Sarah to determine how the level of granularity needs to be for something like
If
that.
we have it, to me, I think that's a meaningful data point for board members.
Yeah, so I think that's something that we need to take back and check on with our DFR colleagues. The data call is actually collected under the authority of the insurance commissioner, which is a separate authority. I mean, the DPT program for the DPT carrier reports has separate statutory authority for those reports. So they're under a different authority than the data call, which is under the insurance commissioner's authority. And I'm not sure, we may not be able to disclose the identities of the carriers from the data call. I'm just not sure. So that's something we need to have further discussion, get some more guidance from our
If we
DFR
could
colleagues.
just share with the board, the outcome of that from the statutory language perspective, what we can and can't do. I think that's very meaningful for the board members to have clarity on.
And I guess when you are saying you'd like to know more about which plans, do you mean, which carriers?
Yeah, I
Is
would
this
say by
MODA
carrier.
or
Yeah, I was trying not to
Providence,
identify
or is
exactly.
this
I would like it
large
listed,
group
but
versus
no, I mean,
individual?
what I am specifically asking is by plan name, like you said, or carrier name,
By carrier.
right? By carrier name, this plan, these are the metrics that we're showing here on the screen here, required step therapy, all that. This is how plan A or carrier A does it. This is how carrier B does it. It's carrier C. I think that's very meaningful. And so if we have it and we are legally able to provide it to the board, then I would be requesting that we do so.
I mean, we certainly do have it internally. Like I said, I'm not sure that's something we can
Yeah, I
present
just would
in
like the
public
board member.
analysis.
Yeah, I would just like clarity on the legal side of it so the board members can have an answer so that we can add it if we are legally able to.
We absolutely will follow up on that. Yeah, and as we were discussing, we can certainly implement some of Dr. Hartung's ideas about grouping like smaller or larger plans.
Oh
or
yeah,
some of
no,
those
I mean, I
ideas.
think that's helpful, but I think my request is different in nature.
Yeah. You're trying, can we get down to the carrier level of granularity?
Thank you for the suggestions. And Michelle, let me see your hand up.
Another important data point, if it exists, might be to characterize the formulary tier placement, which is an important part of benefit design. So if something's on the lowest cost tier or the highest cost tier, some plans may use that as a deterrent over step therapy or different benefit utilization management. But I think it would be, again, it depends on the context. So if one plan has 4 tiers and another plan only has 3 tiers, we would need to understand that.
Good points. John, see your hand up.
Yeah, I would like to concur with Chair Bailey on the request for granularity, as since this has been identified through our some of our groups as one of the main hindrances to access and availability, affordability of medications. I would like to know also if we are able to know plans, it helps to identify location if that plan is available in my Eastern Oregon region, for example. It would help me to know. It would help, I think the more transparency, the better. And it would also give us percentages if we know the size of the carrier too.
Good feedback. Sarah, is your hand up?
One thing I wanted to raise, hearing board members' questions in this space around some of the plan design questions. This area of information, frankly, is something that was more difficult in this year's data call. For us, it seems like that was a space where we identified more errors in our data validation process, or just not even necessarily errors, ambiguities, and that there may be better ways for us to ask questions and collect data about the structure of plan design. It is a complicated area, so it is hard to do and hard for us as a team to to know how to best ask questions in a way that will get the information that the board is looking for. So we'll certainly analyze and present what we have from this year's data call. And I think this is an area where it would be really helpful for us to continue to get guidance from the board members and also input from other interested parties who follow our work and our meetings about how we should be collecting information related to plan design and formulary tiering and these other issues, because yeah, it's complicated to figure out how to collect that information in a standardized way so it's meaningful. So kind of putting a pin in this is a ongoing area where we could use your help.
Courtney, I'll lean into that. I've been personally very involved in helping with the formatting of the data calls. So a lot of these are standard formats that are available, right? So I agree with you, Sarah, that the more continued iteration we have on that, but I think like a lot of these things we do have. And because our data calls have been better, like over the years, right? We've been modifying our data calls and things, but some of these are standard, carrier format fields. But I would encourage all board members to, work with the team to continue to iterate on our data calls. But I would say that much of this is information that we do have.
And I would add, I appreciate the improvement in data calls that have happened over the years that I've seen. My comment on this topic would be that we follow the public's request. As a board member, I want to follow the requests of the people that have talked to us about what the biggest challenges to them are. If we are not asking the right questions to get answers to the questions or the concerns that they have, then we need to improve that. So.
Thanks, John. Lori, see your hand up.
And I'm going to also reinforce that do this for the purposes of equity, because I think that it will also reveal a lot of information. Example being migraine products are less available to certain populations, and this would be a way that we could kind of get at that information.
Thank you all for your comments and feedback. Again, this just helps staff improve not only the material packet, but our data concepts. So always looking to improve and provide the board with as much detailed information as we can provide to you. So if there's no other discussions regarding kind of this section, I'm sure that once the data is in here and we start looking at the material packets, there may be more discussion around this topic. So we're good with that. One of the things is I've been trying to dig into this financial impact to health, medical, or social service costs. This is the second kind of challenging section I haven't been able to fully wrap my head around. But as board members, if you have any suggestions, please let staff know. We don't really have to come into the conversation right now about this because it's pretty broad and how to look at stuff that we just don't have data. But this is one of those sections in upcoming material reviews I'd really like a little more support in trying to get information to fulfill this statutory obligation. Estimated average enrollee, again, the co-payment and other co-share responsibilities for enrollees, so the out-of-pocket impacts. Primarily, you got APAC information for this. Again, looking at what the IQR 75th and 95th percentile is on that. Same information. Clinical information, we are still in a contract with a new clinician, but I'm hoping that we can get them on board really quickly before at least the second packet development so that they can help restructure or structure this component to be as meaningful for the review as possible. But primarily the topics for this area are, of course, the drug indications based off of the FDA label, clinical efficacy, safety, and then the therapeutic alternative indications. So this is still will be improved, but for the GLP-1s, I am carrying over the information that was provided in the last review since they're not really changing year over year as much. So it will be this very, very similar clinical review from the other material packet. And Dr. Hartung, I see your hand up.
Yeah, so I guess as you work with your vendor to build out this section, I think I'm looking at prior reports as we scroll through this thing, but like very high level like summaries, especially from like professional clinical practice guidelines in the area that kind of describe the role of therapy of the drug under review. So we kind of get a sense of like what are the experts in the field saying that the role of this drug is relative to other alternatives and things like that, I think would be the most informative rather than really granular, summaries of the comparative effectiveness views of drug A versus B. So that's kind of what I would, my 2 cents on this particular area for that, again, whoever's helping build that out.
Right. Sounds good. Yes, I am looking forward to see what we can update or improve for this section. And again, so this is kind of coming into the last part of our input from stakeholders, really capturing any patient caregivers, individuals, scientific medical training, safety net providers and payers. This is where information from the forums will be placed. And we don't have as much at this point for patient feedback as we did at this point last year, but I'm really hoping that from these conversations over the last couple of weeks with the forums that more patients will provide feedback. Safety net providers would be really great to have some information from them. And then payers this year are new to our forum. I didn't create a survey for them last year, but I did for this year. So any payers would like to contribute any feedback regarding any of the drugs, that would be really helpful. And I think really from what we've received so far, feedback from scientific community has been very, very meaningful. So again, any colleagues that prescribe this medication that you know, please encourage them to fill out the form, because their honest opinions have been what I would say meaningful feedback to how some of these drugs, especially with either the step therapy or the physician or the PAs, the prior authorizations, have been significantly challenging for many patients, especially if the drug is considered a first-line therapy. So hearing that from physicians or medical communities, I think is really, really important. And then of course, then jumping into the appendix with this will include any stakeholder feedback and then any other information we find relevant to put into the appendix. So any questions about the material packets? Thank you everybody for your review of this. We do have a little more time. I would like to ask a couple questions about the rubric, if you are willing to jump into that conversation with me. I see heads nodding. All right. We had a lot of really meaningful discussions in the last review cycle around the rubric. The rubric was broke out into two sections. One was the scoring mechanism and one was the yes/no component. Right now we're still waiting for the data to come in, just knowing that some of these numbers may change, just in the sense where we develop the range based off of the actual numbers of enrollees and the pricing and those kind of things. So it's not just willy-nilly numbers that we just throw out there. They're actually meaningful ranges within the coverage for the year. I just wanted to clarify that some of these may change, or we might find that the ranges are still relevant and will not change. But I will let you know once we get the full data set and what the change is going to be. As it stands, we have number of enrollees ranging from 0 to 3, depending on the number. Price evaluation, and this is associated with WAC. Price concessions, so this is regarding the rebates or price concession information provided through the data call. System and payer spending. And then enrollee burden for anything out of pocket. I did want to ask the board something. So the range was determined based off of patient feedback, but the Medicaid or Medicare out-of-pocket maximum is $2,000. Does the board want to raise this up to that $2,000 indicator? I see a thumbs up from Mr. Kennedy. I see a couple head shakes. Any other feedback? So, all right.
I think
I
that
see a
makes
couple.
sense. Like, you know, with just other benchmarking kind of like methodologies. I just feel like we should, if there is one, there's probably a very good reason for it, right? Like, I mean, it's already being used.
Okay. I will look to increase that. I'll also look at what the range number is within our provided layout from our data. And if it's a significant number, I will bring it back to the board for a discussion on what the preference would be, if it's to keep it at a lower or where that max out-of-pocket spending is versus the Medicare price. All right, any questions kind of about the scoring? The one thing that might be changed for this will be price concessions for therapeutic alternatives. I don't know if that's something that the board just wants to wrap in this as, or if the therapeutic alternative price concessions even have or should have a scoring indication, since the therapeutic alternatives are just reference drugs to the drug under review. So just keeping that in mind.
Hey, Courtney, I
Yes.
know you might not have saw my hand raised. I think they're just reference, because I mean, even our data call, like how would some of that we wouldn't even have, because then we would have to be data calling, right? The drugs that are therapeutic alternate, like I don't see that making sense. And I also go back to the approved uses thing. I would be uncomfortable doing that.
Yeah, so we do have price concession information for therapeutic alternatives for this review, because that was one of the improvements.
We have it. Okay.
Yeah, we do have it. But again, with the understanding that the rubric was designed for the drug under review specifically, however, our statute does also indicate review of therapeutic alternatives to the drug. So it depends on kind of how the board would like those members who use it as a tool would like to use it as accurately as possible. So, but just know that there is that little portion of it. Dr. Hartung.
I would say just we don't need to add another row to consider. I mean, I think it's kind of implicit in the price concession for the drug under review. At least for me, it is.
Yeah. All right. Appreciate the feedback. Okay. Any other discussion for this component? All right, seeing none, and just in the last few minutes, scoring for yes, no's, indicating if there's any equity impacts considered. Due to that, we now have data for health equities. I think I mentioned this before, that this may be better served under the scoring rubric. But we can hold off to make that decision until the data is incorporated into the material packets and then see what that looks like. Because we may just keep this as a yes, no, because data may show one way or the other, versus trying to score it out across the scoring mechanism. So just mindfulness that this might be the one that changes depending on how the board feels the equity data comes out. Again, access restrictions, how that impacts through prior authorizations had impacted the drug or patients, less expensive therapeutic alternatives available, and then the stakeholder and feedback and input if they indicated any financial burdens or hardships for enrollees. And then the exclusivity information, and then the MFP if the drug was excluded from the CMS review, meaning that it wouldn't have a future benchmarking on it. So those are that, again, just high level rubric outline. I don't think anything's going to really change, but just letting you know as we set up the material packet that this is also a point. And Dr. Hartung, I saw your hand up.
Oh, I just thought, since we had this thing about the access restrictions, and we have the data call on the therapeutic we don't have comparisons with respect to formulary design on therapeutic alternatives, do we?
No, not for plan design.
Okay.
Not to say that it wouldn't happen in the future, but I think we need to get the plan design information done for the drugs under review before we start adding in TAs to that complexity. All right, well, that's all I needed to shore up with the board members. Thank you, everyone, for your feedback and due diligence of helping getting us set up for the next review cycle. I will reach out if I need any advice or assistance, but thank you all, and I'll see you next month.
Thank you very much, Courtney. So I do want to announce the date of our next board meeting, which is Wednesday, June 17th at 8 a.m. Pacific. With there being no further business before the board, all in favor of adjourning, please say aye. Aye.
Aye.
Any opposed, please say no. All right, see you next month.